Okay.
All right. Well, good morning, everybody. Thank you all so much for being here. My name is Dr. James Economopoulos. Most people call me Dr. I, and I'm the Tex-CHIP program coordinator in the Department of Counseling at Texas A&M University Corpus Christi. Tex-CHIP is a grant-funded program. It's funded by HRSA, the Health Resource Service Administration. They have these behavioral health workforce education and training grants, and so we were awarded one. And the goal of the Tex-CHIP program is to strengthen the behavioral health workforce in Texas. So we're going to be talking about integrated behavioral health care today. We have our presentation on 10 things everyone should know about mental health, suicide, and happiness. And then around 12 o'clock p.m., so in about 2 hours, we'll have another presentation, Integrated Care Skills and Mindset. And so we're really happy to have you all here. And I'll go ahead and I'll let my Tex-CHIP graduate assistants go ahead and introduce themselves as well.
Hello, my name is Shalana Landers. I am a second year doctoral student.
Hi, Dr. Summers. I'm the one you've been emailing. So sorry about the time mix-up. Totally forgot that we had different time zones. My name is Kelsey Ellis. I am a second year doctoral student as well.
All right. Well, we're really excited to have you here. So we have Dr. John Sommers-Flanagan. He'll be presenting this first half. And so I'll now leave it to you. And we're very excited. So I'll let everybody know we're back to you, but you can go ahead and get started now.
Okay. It's great to meet you, Lena and Kelsey and Dr. I. It's good to see you again. I do need someone to share with me the screen sharing co-hosting ability.
Okay, I gave it to you now.
Perfect. And I've got it. Okay, so Lena and Kelsey, could you just give me a thumbs up if you see my screen, which should, okay, looks good. All right, so my name is John Sommers-Flanagan, and it's an honor to be here. Thank you for the invitation. My talk is 10 things everyone should know about mental health, suicide, and happiness. And I am a professor at the University of Montana. I taught my first class at the University of Montana as a graduate student, not as a professor, in 1982. So that tells you that I started teaching at the university when I was about 10 and have continued teaching for a long time. I'm actually no longer a professor of counseling. I am now the new director of the Center for the Advancement of Positive Education, which we received a $9.4 million grant for that, which is very exciting. The most exciting thing, which I don't know, Dr. I, if you all have been following some of the federal funding for grants, including possibly HRSA, but the good thing about our grant is it's a private funder who gave us $9.4 million. And so it will not get clawed back in any way that is quite frustrating. I want to say an official thank you to Chelsea. She's been my contact. It should say Kelsey. So I'm completely wrong. I'm sorry, Kelsey. Begging your forgiveness. I also want to say thanks to all the scientists. This is my chance to express gratitude for the fact that we have people in the field of counseling, we have people in the field of psychology and social work, and just all over the planet who are contributing to our knowledge base about the things that I'm going to talk about today. But maybe most important is to thank you all for being you, for being the kind of people who want to become mental health professionals, professional counselors, who want to use yourself and your skills and your talents to make a difference in the world. And I think that's a beautiful thing. I hope that you recognize in yourselves what a beautiful thing it is that you are committing to this particular profession. So thank you for that. I am a university professor, and as a university professor, I need to offer some trigger warnings. I have a little different version of trigger warnings. I can't remember if I did that a couple of years ago, Dr. I, when I was presenting last time, but trigger warnings, of course, are designed to help you know that there is information coming that is kind of intense, and it could be emotionally activating. And just the topic of happiness is often emotionally activating, and I'll talk a little bit later about why that might be. In addition, talking about suicide and mental health, obviously, those are hugely activating issues. And to top it off, I will be saying some contrary things. I will be saying some things that are different, I think, at least a little bit different than what you've heard before about suicide and mental health and maybe even happiness. And so I'm giving you a warning. And then I'm also a university professor, and because I track the research in things, I know that actually trigger warnings tend to backfire, and that for many people, a trigger warning gets you ready to react, and it causes people to overreact. And so I like to give a trigger warning for my trigger warning, which I think is pretty interesting and kind of funny. But the last thing I have started doing, and you can see that on the bottom of my slide, I am now going to give you a strength warning. Because now, as the as the director of the Center for the Advancement of Positive Education, I have become more and more aware of how we set ourselves up to react or to have negative reactions or to look at our own weaknesses, our own problems. And so a strength warning is for me to say to all of you, while I'm talking today, you might get activated in a positive way. You might find yourself feeling stronger and more capable and more ready and prepared to deal with some of these hard issues that, of course, mental health professionals have to deal with. And we deal with these things all the time. And so what I'm saying is that I already know that you are strong people who can handle the kind of content that I'm going to talk about. But I also hope that you'll pay attention to how you grow stronger and smarter and more capable throughout our time together this morning. So, strength warning. I hope it's the first time you've ever heard it, because I made it up about 2 weeks ago. I'm aware of the fact that I have goals for my presentation, and you have goals, and maybe we have some goals together. We usually talk about those as learning objectives. I just want to recognize that you all will be having your own personal experience around whatever it is I'm talking about. I hope in the process that we can together gain some new knowledge and insights and perspectives on mental health, suicide, and happiness. I really know better after having taught since 1982 to think that I can accomplish specific learning objectives. Instead, I hope that you will be tuning into your own learning objectives and having an experience of moving toward them as I talk this morning. We are at a distance, and so even though we're at a distance, I hope we can be engaged. I will pause from time to time, and certainly I know there's probably a mechanism for you to post some questions and comments, and I hope you feel free to do that. I will not be able to read that while I'm talking because I can't do two things at once. Or at least if I try that, I'll do both of them poorly. And so I'll pause every 20 to 25 minutes, something like that. And if people have questions or are interested in making a comment, I hope that you will feel free to do that. So now I'm just going to go through my 10 things. And so I like to start with number 1. And number 1 is suicide, mental health, and happiness are wicked problems. Now, I don't mean that in any kind of offensive way. A wicked problem is a problem that is not linear. It's a problem that usually cannot be, well, never can be easily solved or resolved. Wicked problems are so complicated because they involve many different dimensions of living. they also involve many different subjective perspectives and cultural perspectives. And so if we come at these problems, mental health, happiness, suicide, from a one-dimensional perspective, we are probably not going to have a clearly positive effect. And we won't even know in advance how our efforts will, what the results of our efforts will be. And that people, when it comes to suicide, we know that people have many different subjective perspectives. Mental health, same thing, right? And so it becomes really difficult to solve these global societal level problems, even often at the individual level. And so when I say wicked problem, this is a phrase that's been used historically to identify these massive problems that are really difficult, really challenging to get a grip on and to have a positive effect on. So, wicked problems are why everything is worse. And when I say everything is worse, I don't mean to be too negative, but I want to say, in my lifetime of having worked on mental health issues, which started over 40 years ago, I have seen nothing but depression and anxiety and intergenerational trauma and narcissism and ADHD and addiction and everything else get worse. And these things have just gotten worse. And wicked problems are why sometimes trigger warnings backfire. And I started with that, and I started with that purposely. It's like, well, if it's just a problem. People have their own individual trauma and their own individualized responses to trauma. And so if you give a blanket warning, you're just not likely to get the outcome that you wished to get. Suicide is up 40 to 80% over the last 20 years. And I say that, and I just did a version of this presentation for the Confederated Salish and Kootenai tribes in Polson, Montana. And we know, and they know, that there was a brand new tribal strategy that was unveiled in the state of Montana in 2017. And even before that, in 2001, the US brought out its first ever national strategy on suicide prevention in 2001. And in 2012, they revised it because things like that need to be revised. And they revised it again last year in 2024. We have been doing more suicide prevention nationally, statewide, on Indian reservations, and locally than ever before in the history of time. Okay, that is just true. And suicide rates have gone up steadily. Okay, that's really by definition a wicked problem. You make all these efforts, you do what is logical, you try to evaluate the outcomes, and it just is difficult. And in this case, it gets worse. So I looked at the suicide rate in Texas because I think that's probably where most of you are. And it has increased 29.7% over the past 20 years. So it actually is not quite as bad as some of the numbers that I just shared with you. But if you look, rarely does that line go down. So this is, and in the terminology through which we evaluate suicide rates, the average in the US is 14.5 or 15 per 100,000. That's also 14.4, 14.5 is the average for Texas. And so the Texas rates of suicide are almost exactly the same as the rates in the United States, and they seem to track pretty closely together. That's not the case in Montana, where we are almost always number one. our suicide rates are 28 per 100,000. If we look at our indigenous population, our rates are 46 per 100,000. If you look at males versus females in Texas and in the United States, males are 3.5 to 4 times more likely to die by suicide than females. Of all of the different racial and ethnic groups, the group with the lowest suicide rates, this is again based on CDC tracking and statistics, the group with the lowest suicide rates pretty consistently year after year is Black women, people who identify as Black female. So those are interesting trivia things. But the thing I want to emphasize on my second point in my 10 points is that we're not good at predicting suicide. We're just not good at it. And I want to help walk you through why we're not good at it. Because if you imagine yourself I looked this up online. I got the photos online, obviously. If you imagine yourself at Darrell K. Royal Texas Memorial Stadium, which holds about 100,000 people, and you can see the stadium full in this photo. If you were to go there on January 1st, 2025, and it was filled with Texans, by December 31st, 14 or 15 of those 100,000 Texans would die by suicide. That's the statistical problem, okay? So your job as a mental health professional, let's say, is how do we identify and intervene to prevent suicide? Obviously, that is a wicked problem. And so if you look at it a little bit, and you think about it, you think, well, maybe we could, and maybe we should screen for depression. And maybe we could, and maybe we should screen for suicidal ideation. Because if we ask everybody, are you depressed? We're probably going to get more people who are more likely to die by suicide. And certainly if we ask them if they've been thinking about suicide, that again might help us. And it would help us cut the number from 100,000 Texans to about 15,000 Texans if we screen for depression. If we screen for depression and suicidal ideation, we probably get ourselves down to about 10,000, which we still have to figure out which 14 or 15 Texans out of those 10,000 that we've identified as depressed and suicidal. We still got to figure out which of those. And again, so the problem is still almost impossible. One of the things that makes it really, really difficult is that if we use a screener for depression, and the Columbia is the most commonly, well, it's not the most commonly used, it's the gold standard. The PHQ-9 is the most commonly used one in medical settings, and it's a terrible screener for suicide. So bad that some really fancy suicidologists put the Ghostbusters sign over the PHQ-9 and just say don't use it because it's just not useful. It doesn't screen for suicide. But if we dismiss the people who screen negative for depression and suicide, half of our 14 or 15 Texans who were going to die by suicide would walk out the stadium doors because they would not report that they're having suicidal thoughts or that they're feeling depressed. If we screen for, and I refer to this as so-called mental illness because I've got a lot of political issues with the term mental illness, mental disorder, probably safer, but if they've got a mental disorder and we screen for that, we'll do even worse. We will lose more than half of the people who are likely to die by suicide. And so, again, I'm trying to point out, this is not an easy problem to address. Statistically, it is a really difficult problem. So let me just quote now a guy named Craig Bryan, who wrote the book Rethinking Suicide. Craig Bryan is from The Ohio State University. He is probably the leading researcher in suicide intervention and suicide assessment, at least in the US, maybe in the world. He wrote on LinkedIn a little over a year ago. He says, the majority of patients who die by suicide screen negative for suicidal ideation. If you are a mental health professional or agency who uses decision trees that designate negative screens as, quote, low risk, you should consider discontinuing that practice. Let yourself linger with that. This is what we're doing in schools, and we're certainly doing it at medical centers. He's saying, if you designate negative screens as low risk, you should consider discontinuing that practice. And then he goes on to say, this is especially applicable to clinicians or agencies that use the Columbia, remember, the gold standard of the screeners. And it has a system that's red, orange, yellow. And he says that the Columbia will miss most patients who kill themselves. In other words, there'll be false negatives, that you will categorize them as yellow, low risk, and they will die by suicide. Now, he's actually in this really, I think, provocative statement. He's not saying we should never screen. He's saying we don't have the data, we don't have the evidence, we don't have the empirical support for categorizing risk. And by that, and his big warning is, do not be lulled into thinking that someone who appears low risk is low risk, okay? So, of course, that doesn't do much for our anxiety as clinicians or as people who want to become clinicians, right? Probably makes us feel more anxious because now we know that we probably can't even accurately categorize the level of risk of someone who comes in who may or may not be suicidal. Now, I'm going to come back to the prediction issue in a couple minutes, and I also want to just acknowledge at this point in time that this talk is not designed to be completely depressive. I know that I am talking in negative ways about things we don't know and things that we should not pretend to know. And that's why I've titled this talk, Everybody Should Know This. And we should not be pretending and fooling ourselves into thinking that we can accurately categorize somebody as low risk. It's a statistical nightmare. We can't do it. But here's another thing. We're also not good at preventing suicide. And so you might think, this guy is completely, he must be depressed himself. But, and this annoys me. I'm now about to hit the peak of my annoyance with the field on this. This is a typical suicide prevention message that I'm sure you've all heard something like this. It says here, suicide rates for at-risk youth can be substantially reduced by knowing the signs. And then they say 4 out of 5 suicide deaths are preceded by warning signs such as suicidal threats, previous suicide attempts, preoccupation or obsession with death, depression, and final arrangements. This is what I would affectionately call, using my most sophisticated academic terminology, as complete bullshit. Hope you remember that. That's just not true. Okay, it's not true. In the most recent huge study that was published in 2017, so it's a little bit dated, they looked at 50 years of research on studies that evaluated risk factors, protective factors, and warning signs, okay? They looked at those and they said at the very end, and this was by a team of about 10 of the best suicidologists in the United States, right? Harvard, Columbia, Ohio State. So really, really, as my daughter would say, fancy scientists. And their conclusion was, we have nothing. We have nothing out of all that information that can help clinicians in their problem of categorizing risk. And then they say, well, maybe previous attempt. Maybe a previous attempt gives a clinician some justification for estimating risk being higher. So you might wonder, and I have other presentations where I go into this in more detail, but you might wonder, well, so why don't previous attempts, or why doesn't cutting? There are some things that we should know they contribute they are associated with, and you probably read studies about them predicting suicide. Well, the problem is that they don't account for very much of the variation in people who die by suicide and don't die by suicide. In fact, suicidal ideation is a poor predictor of death by suicide. And I'm going to talk a tiny bit more about that in a minute. But if you have somebody who has a previous attempt, yes, statistically, if you look at a checklist and you were to look at 100,000 people, yeah, that's going to increase risk slightly. But the problem is some people who make previous attempts actually are less suicidal because they made a previous attempt. I had a guy I worked with who shot himself in the forehead. Everybody at the agency where I was working was freaking out because they know the more severe the attempt, that's the story. And it's true, the more severe the attempt, the more likely it is to increase risk of another attempt. I talked to this guy and he said, "Oh, I would never do that again." He said, "I was in the hospital for a week or 10 days. I can't remember how long." And he said, and you know what? I learned who loved me. And he says, he goes, "I was getting bullied and I learned, I feel like I can handle bullying now." And so for him, the previous attempt, and it's similar, and they've interviewed people who've jumped off the Golden Gate Bridge. After an attempt, they actually have reduced risk of suicide. So, and the same thing is with cutting. Cutting in general, if someone is cutting, they're a little bit more likely to die by suicide. But people cut for different reasons. The people who cut for emotional regulation purposes, they're probably less likely to die by suicide because they're cutting. I've worked with people who that was absolutely the case. It was a coping strategy, not a great coping strategy, and one that it was really important for them to learn some other coping strategies and move on. But cutting is emotionally regulating for some people. On the other hand, if somebody is using cutting as a rehearsal behavior and they're just sort of desensitizing themselves to the act of cutting themselves in a suicide attempt, the data are pretty clear. In that case, it is increased risk. So my point here, as I'm talking about back to predicting suicide and preventing suicide, is that we need to, if we're going to use risk factors and protective factors and warning signs, we need to individualize them. They have to be individualized so that it's not just like in general, is somebody, scoring high on my checklist. If I'm interviewing Kelsey, I want to know what are her risk factors, and her risk factors may be different than Dr. I's risk factors. And your protective factors definitely are going to be different, maybe only in part because you are culturally different, right? And so you have some different cultural heritage. So anyway, so individualize the risk factors is one of the take-home messages here. And I want to also just say, I want to explain why I'm saying these things, and I think I have partially, but another reason is a bunch of years ago, my wife and I made mostly me, but my wife and I made a video for psychotherapy.net. It's a 7.5-hour suicide assessment and treatment video. It's great stuff. If you want to watch 7.5 hours of me doing suicide interviews and talking to Victor Yalom and stuff like that, you should check it out. It might be free through your library. But in that process, I interviewed a friend of my wife's. Her name was Connie. And Connie came in and her ex-husband had died by suicide. And she was a teacher. She was an educator. And she said to me, "One of the things I hate the most is when the suicide prevention trainings come to the schools. And she said, what happens is they tell us that all we need to do is watch for the signs. And that if we watch for the signs, we can prevent suicide in our students. And then we're all watching for the signs. And of course, we've got 25 students and we can't see all the signs, but we try to watch for the signs. And then we, in one way or another, we fail. And everybody is devastated. Everybody is consumed with guilt. Everybody is so emotionally disturbed by what happened, and we all blame ourselves. And that was sort of a wake up for me, along with the science. It's like, what are we doing? You know, when we give this message that suicide is preventable and all you have to do is look for the signs, the main outcome of that, because it doesn't change the suicide rates. Like I said, it's gone up almost every year for the last 20 years. It doesn't change the suicide rates. What it does is it makes people feel more horribly guilty. It's really a guilt inducer. And that makes me so angry. It's like, we should not do that. We should not make clinicians, you all, we should not make teachers think that somehow you have screwed up if somebody dies by suicide. In fact, people will die by suicide. And then they often choose to hide the fact that they're thinking about suicide. And sometimes they weren't even thinking about suicide. It was an impulsive thought in the moment. And maybe they were using some drugs or alcohol, and it just happened all of a sudden. And it was an impulse. When I was up doing my talk at the reservation a couple days ago, one guy raised his hand and said, that's exactly what just happened. 2 weeks ago, we had a guy, teenager, kid that we all knew. He was so happy and fun and engaged in life. And then he's missing for a week, and then we discover he killed himself. And we just, none of us, he said, none of us knew. And we are just all devastated. And so another part of the message that I want you to take home with you is that you will work with people who are suicidal. You and we and I should do everything we can to prevent suicide. And if someone dies by suicide, and I had a kid who's 16 die by suicide when I was working with him about 30 years ago, I still wake up wondering what I could have done different. I think guilt is natural. What I want to do is normalize the guilt, but also to say, I hope you can hold on into your brain to the fact that if you do everything you can, then someone chooses to die by suicide, and it's not your fault. It just isn't. It just is not your fault. And to blame yourselves would be not right. So, all right. So I'm going to get a little more positive now as we go, because remember, we got happiness in here somewhere. So, so number 4, suicidal ideation is not an illness. It's not a mental disorder. It's not a sin, and it's not even a good predictor of suicide. Okay. And I've got 2 numbers on here, number 4 and number 5. That's because at this point, usually I've talked too much and I need to sort of step back and slow myself down. But I want to say, and I'm going to stop after this slide and just take any thoughts or questions that you might have. Suicidal ideation, because it's not an illness or a mental disorder or a sin, it is a natural human response to disturbing, emotionally painful, stressful circumstances over which we feel little control. As I was talking with the indigenous population, I was trying to emphasize, think about historical trauma. Also think about systemic oppression, think about discrimination. These things, which is really, it's really important for us to acknowledge that our society has systematically mistreated, abused, and made certain people with certain identities feel disenfranchised and marginalized. Our society does that. And so what happens, and this has been true, we've known this was true since really early psychological research in the 1940s, what happens is that people who are in so-called minority or marginalized populations, that what happens is that they then start to internalize some of the negative messages. They start to question their own worth, right? They start to feel more in distress because of the way that their society is talking about them and thinking about them and treating them. And so those things can be outside of the person and then get internalized. And this is one of the problems with the medical model when it comes to suicide and to mental health in general, is that, and then we blame the person, right? Then we give the person a label and we say, well, you have major depressive disorder. Well, you're living in a society that is completely abusive to you and people like you with your identity. And now we're going to blame you for having major depressive disorder. This is not right. Because if people feel intense emotional pain and they feel trapped or hopeless to have it change, they will naturally think about suicide as one option. And they may cross it right off their list. It might just be a brief thought, but it's one of those things that naturally comes up. And high rates of suicidal ideation in groups or individuals really just means people are living lives of a lot of internal and external pain and despair, and they're experiencing hopelessness and feeling trapped and not able to make a difference in their lives. So, all right, we're halfway through, so let's take a pause. I've been talking. Have I activated anything in anyone yet? Any reactions? Can anyone talk? Is it possible?
Yeah, anyone can unmute.
Anyone can unmute. Perfect. That's great. So, yeah.
I'm curious to know, so I know that Columbia is the gold standard, but for those who are using PHQs, what are the flaws in the PHQ?
Yeah, the problem with the PHQ is the PHQ is it's the 9 items from the DSM major depressive disorder criteria. The 9th item is what's considered the suicide item. And I'm sure I will butcher the exact quote of this, but it contains 2 parts. The first part is, have you had thoughts that you wish you were dead? So the first half of item 9 is a passive suicide question. So it's about wishing you were dead. It's not an active suicide question. It's not like, have you had thoughts or made plans to kill yourself? And so it's a passive suicide question. The second half of item 9 is a self-injury question, or have you had thoughts about hurting yourself? So, and I'm not saying passive. I think passive suicide is an important question to ask. I think it's important to ask about self-injury. But the complaint about item 9 is it doesn't really even ask a suicide question. It asks a passive suicide question. It asks a self-injury question. And those are 2 important things, but they're just not a good, clear question about active suicidal ideation. So that's a great question, Anna.
Thank
Thank
you.
you. Yeah. In contrast, the Columbia will walk you right through, and I have problems with the wording of the Columbia, but the first Columbia question is a passive suicide ideation question. The second Columbia question is an active suicide ideation question. The problem with the wording is that they use the word actually. They say, have you actually had thoughts about killing yourself? The problem with the word actually is it actually is a bad idea, because the word actually implies that maybe you shouldn't, or that it might be deviant. And that one thing we really know from working with people is that we need to lower the obstacles and make it easier for them to acknowledge that they have thoughts about suicide instead of judging them for having thoughts about suicide. Kelsey, I saw that maybe you have unmuted.
I did. So I have a client, so I'm fully licensed in the state of Texas. And you're kind of actually validating a client that I have. because she has active suicide ideations and she has a history. And so because of how we're like trained, we're like, well, if they have actual thoughts, continue to give them the PHQ-9. And you're kind of validating my client because she questioned one of the questions. She was like, this is kind of passive, asking me, do I have thoughts? Like, yes, I have thoughts, but I don't have plans. So like that doesn't mean anything.
Yeah.
And then she kind of like broke it down, and I was just kind of like, oh, I never thought of it like that. So when I hear you saying that the PHQ-9 isn't the best, I'm like, well, maybe I should tell my group practice that we need to get the Columbia because the PHQ-9 is not that valid in helping to prevent.
Yeah. Yeah, I think that would be a good thing to tell your group practice. So David Jobs, who is the person who developed the collaborative assessment and management of suicide approach, which is one of the evidence-based approaches to individual counseling or treatment for suicidality. When he and his team presents, they're the ones who put the Ghostbuster sign over the PHQ-9 and just say, well, it's not. Do not consider that to be a suicide assessment question. So the Columbia, in contrast, asks specifically about passive suicidal thoughts, asks about active suicidal thoughts. It asks about plan. It asks about intent. And then it asks about plan and intent. And then it asks about, have you made a previous attempt essentially or made a plan or, started to act on a plan. And so it walks you right through things that, yes, you should ask those things. Now, my problem with the Columbia, with all screeners is, I think the Columbia is really well structured. Okay, so I'm not disputing that. But we know if you ask about suicide and you don't ask about real mental health, like Kelsey, what are you doing when you're not thinking about suicide? And if you don't ask about the positive side, at the end of the interview, people will feel worse. Now, you're not putting the idea in their head. I'm not saying you shouldn't ask. I'm saying, of course, we ask directly. That's what we should do. But if you just focus on negative, or the 9 items from the PHQ, they're all negative depressive items. None of them are happiness items. None of them are well-being items. None of them nudge people to think about their health and their positive behaviors. And so one of my positions, and we're in the process of developing sort of this add-on or complement to the Columbia, where if you're going to ask the 2 to 6 questions on the Columbia, you have to ask 2 to 6 positive questions that require an answer that will help us to build a collaborative safety plan, right? Because if I ask you and I say, Kelsey, what are you doing? What's happening in your life when you're not thinking about suicide? And then you say, and I've got a video of myself doing this with a young woman, Yupik, Alaskan Native tribal person. I ask her, and she says, I'd be singing. And then, so what would you be singing? Well, I'd be singing some traditional songs but also some pop songs. What else would you be doing? I say. She says, writing poetry. And that works, or that helps? She says, yeah. So for her, she's already then, just by answering that, she's told me self-expression through songs and music, traditional, contemporary, and writing relieves her of her suicidal thoughts. That is gold. That is what we need to know if we're going to develop a positive safety plan with a client. So thanks, Kelsey.
I also just feel encouraged of hearing you talk about, we can't necessarily prevent someone from suicide and relieving that kind of, not obsessive thinking, but, when you have a client that is suicidal, it's like you're thinking, okay, what are all the things I can do? I can check all my boxes, but then being able to kind of relieve that thought. But then also, you had said that the preventative side comes from individualistic, measures for them. And so really, it really, for me, kind of opened my eyes to a different view of, just right now I'm learning all the standardized care, right? Where's the safety plan? Where's this? It's all very black and white in a lot of ways, even though you're filling it out for the client. But really having it be more of this conversation piece of what really is going to help them, because anything that I read in an article that says, okay, this is what's going to be a cause or an increased risk factor really may not apply across the board. So just
Right.
hearing that again, it was just kind of relieving as an internship student. So thank you.
Yeah. Well, thank you. I appreciate the comment. And when I think about risk factors, also one of the things that's really important is that the risk factors are different for different age groups, for different cultural groups. And so one really common example that's very clear, and that is for people in the LGBTQ plus community, that a big risk factor is the rejection of their identity by their family. Okay. Of course. I mean, that's a huge thing to have happen. And it's emotionally disturbing. And so, but we want to also then be matching risk factors from the general risk factors, of which there are probably 50 plus. And then we need to think, well, what's our specific population? But then really most importantly, who am I with? If I'm sitting with Suzette, then I want to know, it's good for me to know general risk factors, but I want to know, and there's a beautiful question David Jobs developed, which it's, I think, the best question you can ask if you're doing a suicide assessment. Is called the one thing question. And it goes something like, if something magically happened and the one thing that is making you feel suicidal went away, what would be different? It's a little bit like the miracle question in Solution Focused, right? But he's asking, what's really the driver for the individual, suicidal driver for the individual who's in front of me? And that's an incredibly good question. So, all right. I'm going to jump back into my slides. And I want to say thank you to all of you who spoke, and just thanks again for being here. I am going to keep on rolling. I'm going to go back here to just the wickedness, reflecting for just one more slide on the wickedness of the problem. And the reason I like to do this is because so as I said, from 1999 to 2022, we did more suicide prevention than ever before. I got the national strategy dates. Suicide rates went up every year except 2. Per capita, it went up 40%, 30% in Texas. It increased by about 60% in terms of the raw number of suicides, because the population of the US has gone up. So does anybody know which 2 years out of the 22 or so years did suicide rates go down in the US? If you're thinking, how about 2020, when COVID hit and we're shut down? You'd be thinking right. And then 2021. So those are the only 2 years, it just speaks to the perverse complexity. In 2020, just a couple of trivia things which you can impress your friends with. In 2020, everyone reported increased depression, increased anxiety, increased suicidal thoughts. And the rates were lower. The rates went down. Even though people were in more distress, self-report surveys, they were in more distress. All right. So, and suicide rates go down. That is just twisted and weird. So you might be thinking, well, how could that be? And there are some partial explanations. No one knows for sure all the reasons, but some of the partial explanations include, and Craig Bryan writes about this in his book Rethinking Suicide, that the social safety net rose. People got checks In April of 2020, there was a moratorium on eviction. There was a moratorium on student loans. There was an increase in money for families with children. And so, and Craig Bryan writes that, we've looked at the data over time, and there have been various studies and comparisons, and we pretty much know, and of course it's a wicked problem. So, he could be right, he could be wrong, but he says we could probably decrease suicide by 10% if we raise the social safety net, right? If we raise the bottom for people. The other really weird thing that happened in 2020, and I'll say this again, this is a trivia thing that most people don't even realize. So the highest suicide rates per month, almost always, the highest suicide rates are in the spring in the Northern Hemisphere. So, and usually April is the month with the highest rates most years. More often than not, it's April, highest suicide rates. And there's the poem, April is the cruelest month, and people, but nobody knows really why. But in April of 2020, I looked at the monthly data across the US. The rate was the lowest of all months in the United States in 2020. So it was the exact opposite of what it usually is. And again, for me, that means people were feeling kind of more supported in some ways by the government in April 2020. Another thing that some people point to is that in some ways, access to care got easier because we started Zooming everything. And other people say, well, I had an old social psychologist who she used to say, it's not that misery loves company, misery loves miserable company, which is kind of a funny thing to say. But her point is that if Suzette and Anna and Kelsey and I are all feeling distressed and we have a good outside reason for it, it's because we're in the middle of a pandemic. It's like we're kind of relieved because we can talk with each other and it's not really our fault that we're feeling miserable. It has to do with this outside factor of a global pandemic. So sort of a bunch of fascinating possibilities as to why, in the kind of perverse, twisted way that suicide rates go up and down, that they went down by the most in 2020 and in April 2020 in particular. So I'm going to get more positive now. So that might be a relief. It's a relief to me. One thing that is kind of a secret, and we don't talk about it explicitly very much, is that in psychology and counseling, we are better at growing positive behaviors than we are at shrinking negative behaviors. You can see I've got those little cartoons, stop it, stop it, stop it. And, we've all probably experienced this ourselves, and certainly we've seen it in clients. And that is, if you want to stop biting your fingernails, if you want to reduce your anxiety, if you want to stop some of the negative, disparaging thoughts that you have in your head about yourself, okay? If you want to manage your anger more effectively, we're better helping people build positive behaviors and really using the positive behaviors to crowd out the negative behaviors than to specifically attack the nail biting, the anxiety, the depression, the anger, the negative thoughts. Because if you push back on negative thoughts, and we all kind of know this, you push back on negative thoughts, well, the negative thoughts push back. And again, it's a weird thing about the human brain. It's like, oh yeah, yeah, just try to make me stop thinking negative thoughts. It's hard to do. So really what we want to do is we want to think, how do we grow positive behaviors? That doesn't mean we ignore anxiety. That doesn't mean we ignore trauma. That doesn't mean we ignore depression. It means let's simultaneously be building skills and strengths and resources within individuals to cope with the distress that they're experiencing. So this is, I don't know if this is actually going to work. If it does, then we're in for a treat. But one natural thing is that we all naturally, this is another secret, is that we naturally focus on what's wrong with us. There's an old thing called medical student's disease. My older daughter had it, when she was in medical school. She thought for sure she had all these exotic diseases. She'd go down to the lab, she'd get her blood tested. Finally, they said, you got to stop doing that. You can't keep doing, you're banned from the lab. You can no longer test yourself for these exotic diseases that you think you have symptoms. Now, what happens is that people read about diseases and then they think they have the symptoms. Now, in no place is this more likely than mental health. Every graduate course that I've ever taught, if I were to read off the symptoms of ADHD to my class, 80% of them would have it. Okay, that's just the way it is. We start to think we've got the symptoms. We got to start to, and there have been a number of social media things that have made this worse. TikTok, if you work with kids, you know that a lot of them are diagnosing themselves on TikTok. They're getting, I was supervising a case where this 13-year-old, wonderfully intelligent and emotionally articulate male thinks that he's got dissociative identity disorder because he saw the symptoms on TikTok. So he just needs to get a complete psychological workup to confirm that. I told my supervisee, I said, so let's get him to focus on some of the fantastic qualities that he has in terms of his ability to be emotionally articulate. He's so advanced emotionally in comparison with his other classmates. He probably doesn't fit in because he's just so advanced. And so let's talk. He started talking with him about that, and the kid completely forgot or quit asking about dissociative identity disorder and was much more focused on how does he find the appropriate way to express his emotions in social context. So self-awareness is not just awareness of what's wrong with us, although that's what it has become in many ways. It looks like this probably won't play, but I'm going to push play anyway. This is a comedian who's talking about millennials being too self-aware.
I like millennials. If I did have to pick on millennials, I think our biggest issue is we're too.
Uh-oh. Could you hear it, Kelsey? You could.
Yeah.
Okay. Cool. I'm going to go back to the beginning. So it's very short, 30 seconds. Here we go.
If I did have to pick on millennials, I think our biggest issue is we're too self-aware. We know exactly what's wrong with us and why, and I don't know if that's healthy. Because everyone in my age knows exactly what's wrong with them, but no one seems to be getting any better. Like every person I meet my age, they're like, I have anxiety. And I'm like, oh, what are you doing about that? Nothing. I'm telling you, so you work around it. Job, you identified it, but then you gotta,
All right.
I
Well, so I feel like the guy captured something that at least many of us can relate to. And my concern about the entire global population is that if we focus too much on anxiety, we are going to grow it. If we focus too much on trauma, we're going to grow it. And there's nothing wrong with being self-aware of our anxiety and self-aware of our trauma. But if we over-focus on it, it is not going to shrink. And so this slide just sort of represents how this thing that we call positive psychotherapy works. If you look here on the left, we see the problems and they are big. And we can see the well-being in the center is small. So really our goal in psychotherapy should be, how do we increase our clients' sense of well-being? How do we help them feel better about themselves? And how do we help them to recognize some of the resources and the strengths and the virtues and the skills that they have, that they can bring to their problems? So this is just a different way. And I think, again, I'm not against problem-focused therapy. I think we need to help people go deep. We need to help people go deep into trauma. And There are certainly trauma treatments that are evidence-based that are available, and we should do those. But we should also make sure that we're taking time to grow the strengths, to grow the skills, because in the absence of that, people become too good at identifying their anxiety and being, in some ways, controlled by it. So the question here then is, if we don't focus then on what's wrong with people, maybe we should focus on happiness. And so I want to have you all do a little activity here in a moment, but it actually is not that great to focus on happiness. That the whole concept of "are you happy" is a terrible question. We should not ask ourselves that, because if we over-focus on "am I happy," almost always people feel worse. It's just a really good recipe for becoming self-conscious and comparing ourselves to others and worrying that, oh no, am I happy enough? And there's some social messaging that's has been happening for decades around happiness that I think is pretty destructive. I'm going to deconstruct that in a moment. But number 8 on my list is, so what are we going to pursue if we don't pursue, quote, happiness? Isn't the pursuit of happiness in the Declaration of Independence? Shouldn't we be doing that? And, Thomas Jefferson really wasn't referring to what people think of when they think of happiness. He was talking about a thing that Aristotle talked about called eudaimonic happiness. And so the pursuit of happiness, what should we be pursuing? We should be pursuing eudaimonic happiness. So you might think, well, what is eudaimonic happiness? Eudaimonic happiness is not an emotion. It's not material wealth. It's not political achievement. It's not any kind of achievement. It's not getting a new car. It's not getting a new romantic partner. It's not really any of those things, because it's not an outcome. It's a process. And so what we want to help our clients with, and we want to help ourselves with, is the process of fulfilling our own virtuous potentials in the context of community. Okay, now I want to emphasize both parts of that. We want to pursue our own virtuous potentials in the context of community. Okay, so it's not just about us, and it's not just about them, it's about all of us. So, and I'm going to critique some self-focused messages. I said that I got really angry when I talk about the ways in which suicide prevention is taught. I get angry about this too. So, oh no, it's not even here. Oh, I forgot to put it in. Okay, I'm going to tell you, I just have to tell you now. Usually I have a slide that has all these sayings that I just have collected from the internet. One of them is a saying that says, it just says, "Are you happy or sad?" And it's got this attractive young woman smiling, and, "Are you happy or sad?" It's like, that's a terrible question. We should not ask ourselves that. We should not ask anyone that. That kind of treats emotions as a binary between happy and sad. And that, we're so much more complex than that. And there's another one that says, the only person who can bring you happiness is yourself. And that's just so bad that actually the quote that I have, that usually I show on my screen, it says anonymous. And I usually say, well, the reason it's anonymous is nobody would claim it because it's such a stupid thing. We know from developmental psychology and science that kids need us to love them from the outside in, and that often our love for children is what helps them to begin to love themselves. And so to even say that somehow we need to be completely in charge of feeling good about ourselves, it's a silly message. And then the third one, the one that gets me the most upset, is that it says nothing is worth it if you're not happy. And I get so upset about that. And it reminds me of my dad, who died about 4 years ago. And for the last 5 years of his life, he was bedridden. He'd been a very active, very physical guy, loved to do sports. He was bedridden for 5 years. I would go see him in the Portland area, Portland, Oregon, and we'd visit. And, it was so hard. his body was kind of falling apart and his brain was still working pretty well. And so it was just really painful for him emotionally. And, you know, he couldn't talk about it very well. So when I went to see him, it was not like happy, fun times. And I would not trade that for anything. I would not trade it for anything. That time with him, even though it was not happy time, I wouldn't trade it for anything. And I like to share that because it really speaks to the depth of happiness. I know you've all experienced some version of this where the most meaningful time that you spend is with someone through their suffering with them as they suffer. And that can be incredible, deep eudaimonic happiness because it's a meaningful activity that we engage in. So, all right. Now, I want to do a little reflective activity with you all, and maybe you can do it with yourselves, and then I'm going to break out of the PowerPoint. But I want to explore with you the best definition of happiness, Aristotle's definition. I like to think of it as that place where the flowering, I know that's dramatic, the flowering of your greatest and your unique virtues and gifts and skills and talents intersect with the needs of the world. Intersect with the needs of your romantic partner, intersect with the needs of your family or your tribe or your community. And so the best definition is, and I want you to be thinking about this, and I'll tell a short story about myself, and then I want to hopefully hear from some of you. I know this is awkward, it's terrible, right? So how do you match your gifts with the needs of your friends, your family, your communities? It says here Union Bank because I did a talk for Union Bank and I forgot to delete that. But how do you match your gifts with the needs of your friends and your family, your communities, and the world? And then the reflection activity is to think of a nice story of the manifestation of your unique strengths. So in other words, think of your gifts as a unique human being and how they come out in your work, in your teaching, in your research, in your clinical work, in your family. Again, it's not just about you, it's about how it manifests itself in relationship. And I know this can feel awkward, but I want you to be thinking about that. One quick story about myself. I was in full-time private practice for about 5 years. And I really wanted to be a health psychologist and work with people on their health. And I just got all these referrals of kids who were distinctively challenging in certain ways. Their behaviors were challenging, probation referrals. And I got this one kid who was 10 or 11, and he came to see me, and he was challenged. He yelled at me to get out of the office in the first session. And then I probably saw him for 4 or 5 months, and then 5, 6 years pass. He's probably 15 or 16. I'm riding up a hill in Missoula, Montana, and I hear a kid riding a bike next to me, coming up and saying, "Hey, Dr. John, Dr. John." And I'm like, "Yeah." And it's this kid who I haven't seen for 5 years. And we ride together for a little ways, and he says, "Yeah." And he goes, "Remember me?" I say, "Yeah, I remember you. I think we worked together for a while." And he says, "Yeah." And so I said, "Hey, what do you remember? What do you remember about our time together?" And he said, "Well, I remember that one session when you got a bunch of balloons out and you blew them up, and then you put them all around the office, and we stomped on them and we popped them." And I got to tell you all, that's completely untrue. I've never let balloons come into my office. I hate balloons. I hate the sound of balloons popping. I know immediately that he is not remembering anything that we did together because that's not anything I have ever done or would ever do. The sounds of balloons popping freak me out, and I wouldn't do that, I don't want to be freaked out. Anyway, so then I say, "Oh yeah, so what else do you remember?" And he says, "I really don't remember hardly anything." And then he says, "But I do remember," now I feel emotional when I say this, but because he says, "I do remember that we had a good time together and it felt really good to come see you." And it's like, that's for me a reflection of the manifestation of the kind of therapist I wanted to be, right? And so that's what I want you to be thinking about. Who has seen you? Who has seen your special talents, your special gifts in the world, and reflected them back to you and kind of said, hey, Kelsey, one thing I really love about you is, or hey, Suzette, one thing I really love about you. So try to get in touch with that and think about when you have heard that kind of message from someone. I'm stopping the share. That's a signal for anyone to unmute and share. You know, there's some people out there. There has to be.
I'll go.
Thank you, Kelsey. Everybody clap for Kelsey because she has just rescued the rest of you from uncomfortable silence.
Um, thanks, Dr. John. So I kind of have something similar to yours. I enjoy, I've learned not to say this to clients, but termination sessions. It's like me kind of like giving them the push, like you've done this, you've graduated, you've done well. And the most recent one that I've terminated or graduated, she was like, thank you very much. Like, this is truly your calling. You've pushed me and stretched me in different ways and areas I didn't think that I could ever get to. And I really appreciate you just being with me and working with me through it. And so that is one of them. Another one would be with my colleague Elena here. Me, her, and some other cohort members put together a workshop and a supervision and a supervisor expo for our students on campus. And I'm like running around with my head like a chicken with its head cut off. And I'm like, I'm not doing enough and I'm not doing enough. And Lena's like, girl, no, like look around. Like this is beautiful. People are coming. People are enjoying this. Like this is amazing. And even the students were like, this was amazing. Do this again. Do this again. And I'm like, okay. Not realizing like the impact because I'm so busy focusing on like it wasn't how I thought it should have been instead of just being appreciative of how it came out and it being so great. So those are my two examples.
Those are beautiful examples. Do you mind if I comment about them? Just
no, go ahead.
A tiny bit, because you know I hear that first one as really just incredible validation for you being in a place where you're doing your calling, right? That your client just feels so good about the work that you did with the client. And then the client sees you, right? They see you, not just you, but what you're really good at. And that's a kind of validation, you know, just being seen is good, right? Having somebody, hey, Kelsey, you know, just that is good. But having somebody go even deeper and see that you are doing something that you're gifted at, that's amazing. That feels so good.
It does feel good. And I truly, when I have like different or tough sessions with clients, I'll still walk away with like, man, I really love my job.
Yeah, and that's a great validation too. So not only are you getting validation from a client, but you're able to sort of give it to yourself too, even through some of the difficult sessions. And then the second story of a workshop event that you and Lena put together, it's like, you know, you have certain standards in your head and that maybe it wasn't perfect. But the sort of validation for, again, the hard work and the attention to detail and all those things that you must have done in order to have this so well received. Again, that's really validating of the work that you're doing. And so I want to just sort of flip this around now and to say, of course, we want to be aware of our own unique gifts, and you've given us a glimpse of yours. But one of the things we can do for our clients and our colleagues is to see those things in them so that when you hang out with Lena next time, that not only you see her in general and enjoy her, but you're able to say, oh, and one thing in particular, Lena, that you do that I love is fill in the blank, right? So I think because one of the things that one of my messages earlier is that, gosh, we don't know who's going to be, we don't know who's at risk, right? We don't know who's even depressed. There's a thing called perfectly hidden depression. A woman wrote a book on it, and it's like, people are really good at hiding their depression. So I think as mental health professionals, but really also as just good people in the world, we want to see others, both surface, so good to have you here, Suzette, right? So good to have you here. I mean, that's a surface thing, but then also deeper if we can, and recognize and affirm something that's unique about the other person. So, yeah, thank you so much. Kelsey's just knocking it out of the park. She's maybe she has a gift for articulating things. I'm going back to my slides now, and I'm aware that I'm doing pretty well on time, I think, I hope. I might be talking extra fast. So this was our reflection activity. I hope that while Kelsey was doing it, while I was sharing a story, that you were all able to notice something inside yourself that is pretty cool in terms of a quality that you have that is manifest in relationship. So here's another thing people should know. I'm a white person. I'm Italian/Austrian, and in terms of religion, I'm half Jewish and half Catholic. You can imagine how well that goes together. What I can say is I'm half Catholic, half Jewish, all guilty, and sometimes confused about how this religion thing works, because these are not two models that are perfectly fitting together. But what I want to say is that, white cultural solutions will not necessarily translate across cultures. And so often we make that assumption. And then when it comes to wicked problems like suicide and mental health and happiness, the white cultural solutions aren't even working for the white people. And so it's like, yeah, a colleague of mine and I wrote an article, a commentary in the American Psychologist Journal about a year ago, and her name's Megan Rides at the Door. So she's an indigenous person from here in Montana. And the comment, it was on an article that was about how we needed to do better suicide assessment with youth of color. And we made several points in the article, but the points were like, yes, we do. Yes, we do need to do better with youth of color. And then another point we made was, and we're doing terribly with white youth also. So let's not pretend we're doing well with white youth. And it's about relationship. We can't give people screeners and expect to somehow have them be honest unless the youth of color are feeling welcome and validated and seen. And they're not going to be honest unless they feel like they're not going to be betrayed. And so that's, and then the whole issue of hospitalization comes up, which often will feel like a betrayal. And then hospitalization is not even a good treatment for suicidality. Probably increases suicidality in some people, decreases it in others. So anyway, so it's a complicated situation. And we just don't want to presume that the white cultural solutions are going to translate across cultures. Instead, and I've got a 9A here, this is how I get in more than 10 points. 9A is we want to leverage cultural resilience. And now this slide is left over from 2 days ago when I was talking about indigenous resilience, but really we're talking about cultural resilience. So if it's somebody who is a Muslim from Iraq, there will be particular cultural factors that we should try to leverage to help them be healthier and be less suicidal, if that's the thing that we're working on, or to be more happy, if that's something we're working on. And so I have this really cool quote from a Lakota elder named James Claremont. I'm just going to read it to you. The closest translation of resilience is a sacred word that means resistance. Resisting bad thoughts, bad behaviors. We accept what life gives us, good and bad, as gifts from the Creator. We try to get through hard times, stressful times, with a good heart. The gift of adversity, he says, is the lesson we learn from overcoming it. So he's talking about resilience as a really complex process of living well in the midst of both bad thoughts and bad behaviors in ourselves and hard times and stressful times that originate from outside of ourselves. I love this. The background here says Firekeeper Alliance. I'm going to mention that also in a moment about something about that, because it's an example of leveraging cultural strengths. So if we break Claremont's comment down, when he says resisting bad thoughts and behaviors, if you think about it in terms of counseling or psychotherapy, he's really talking about CBT. He's talking about how do we push back on our maladaptive, as Aaron Beck and Judith Beck would say, our maladaptive thoughts, our unhelpful thoughts, and our behaviors. How do we push back on those? And really, what I would say from the strengths-based approach is, and how do we develop alternative, better, adaptive behavior patterns and thinking patterns? When he says we accept what life gives us, good and bad, as gifts from the Creator, he's talking about mindfulness, right? He's talking about non-judgmental acceptance of what is. And I love the fact that here's this Lakota elder who is translating some of these long-held processes and procedures in counseling and psychotherapy. I have a counseling and psychotherapy theories textbook. It is the best theories textbook. I just want to tell you, if you have to have a theories textbook, it's the funniest theories textbook. No one disputes that. So I love to see this sort of integration of culture and cultural knowledge, indigenous knowledge, with some of the contemporary manifestations of counseling and psychotherapy. When he talks about trying to get through hard times, stressful times with a good heart, right? So trying to stay good in our hearts, despite the fact that there are some external things that are pushing on us and stressful things. And so, and really he's talking about optimism, positivity, kind of maintaining our goodness of spirit. There's a spirituality in there. Then he says the gift of adversity is the lesson we learn from overcoming it. And that's really learning from experience. And one of the things that I think we often happens, and I feel like there's some generational things that are happening around this, but we have bad days. Everyone has bad days. And sometimes we use a binary. Was it a good day? Was it a bad day? That's probably not the best way for us to think about our days. One of the ways that we can reframe that using a cognitive perspective is that this is about learning from experience, and that sometimes we have good learning days, even though they might be days that were filled with failure, filled with disappointment. And yet it's a good learning day, because look at what I was able to live through and what are the lessons that I can gain from that. So I love this sort of way in which James Claremont talks about resiliency. So just one quick example, and this is really, for me, this is a fascinating outcome. My wife Rita and I do these occasional retreats, and we did a retreat on what we started called the Montana Happiness Project, which you can find at montanahappiness.org or something like that. I don't know. So we started this thing, and in 2021 we had a retreat with about 15 people. We had a couple who were from the Blackfeet Reservation, and they came and they participated, and we shared with them some of these ideas that I've been sharing with you about more of a strengths-based approach and about suicide prevention, and they have very high rates of suicide on the Blackfeet Reservation. And this couple took our ideas, okay, and they started teaching some strengths-based courses through the tribal college there. And now this summer, just in case any of you want to come to Montana, if you're a heavy metal fan, this summer they have created a suicide prevention / heavy metal concert experience, July 26th through 28th, alcohol-free on the reservation, where they're going to talk about grinding through pain and using heavy metal music as one tool to help with suicide prevention. I share this because my wife Rita and I would never have thought of this. We never would have thought of this. And this is part of the magic, as you learn some more positive approaches to suicide prevention, and you learn about the dynamics in communities. And what they did was they've taken some of the ideas, and if you go to their website, which is the Firekeeper Alliance, you'll see that they're basing a lot of their work, their new suicide prevention work on the Blackfeet Reservation, on strengths-based approaches. And this is a manifestation of that. It's a unique manifestation that is a weird, I'd say, just weird cultural blend of the indigenous and the heavy metal cultures. And I just think it's fantastic. So as we move forward together, we want to think about how can we make things meaningful and culturally informed. My 10th, this might be my last, but it's not, because I've got 11 or maybe 12. Anyway, so a guy named Christopher Peterson was one of the original positive psychologists. He was from the University of Michigan. He's passed away. He used to do lots of lectures, and he would say to people, he'd say, "Hey, Dr. I, you can come to my whole hour-long lecture on positive psychology, or I can just tell you my lecture in 5 seconds, the whole point." And then, of course, everybody would say, "Well, what's the point?" He'd say, "Other people matter, period. End of lecture." And then he'd pause and kind of let that sink in, that's the point of positive psychology. And then he would say, "And we are all other people to everyone else." And I just love that. I feel a little tingly when I even say it. It's like, yes, other people matter. You all matter. You're at the Tex-CHIP conference. You matter. And it's a reflective reciprocity. I matter. And you matter to each other. And so it's a network. It's a community that we can build and strengthen. And when we do those things, to me, that's one of our best ways to enact empirically informed suicide prevention and treatment for depression. So number 11 is a very simple one, and it's simple, but it's kind of complex. It's like our whole culture has gotten obsessed with mental health. But when people use the term mental health, they don't mean mental health. I see people with shirts that say mental health matters. And I agree 100% with the message on the shirt in every way it's intended. But I know that usually the people who are wearing those shirts are thinking mental health matters, or I have a mental health problem and I matter, or I have friends who have mental health problems and they matter, all of which I agree with. But what is mental health? Mental health is not mental disorder. But now we basically use the terms interchangeably. This is what happens in a social constructivist kind of environment where people shift the definitions of things over time. Mental disorder is what's wrong with you. That's diagnosis. And we often need to go deep, deal with pain. We need to deal with social injustice. We need to deal with trauma. There needs to be time and space for that in counseling, in psychotherapy, in groups, in society. But mental health is something different. That's what's right with you. That's your strengths, right? It's the things that Lena does that are great. It's waking up and having positive thoughts. It's nurturing and growing the skills and the strengths and the resources you have. It's being able to recognize a society that perpetuates social injustice and that those injustices are wrong, but that's not something wrong with you, right? It's being able to make that distinction. And so, yeah, mental health is something, is the positive, it's the joy. It's the experience of joy. It's the experience of Kelsey's story about someone saying to you, you are really doing something you're gifted at. You have found your place, your calling in life. So those, and mental health is sort of squishy and hard to define, but it has to do with more of the positives. Now, again, mental disorders, mental health problems are important too, but we can get over focused on those. So now I've got my quick summary. Mental health and suicide and happiness are wicked problems. We're not good at predicting suicide. We're not good at preventing suicide. Suicidal ideation is neither an illness nor a sin. Suicidal ideation is a natural human response to disturbing situations. We're better at growing positive behaviors than shrinking negative ones. Focusing too much on happiness backfires. What shall we pursue if not happiness? The answer is eudaimonic happiness, meaning-based happiness, relationship-based happiness. The white cultural solutions don't work very well for people of color, don't work very well for white people often. We need to leverage the indigenous resilience, the cultural resilience, and the individual resilience that people have. Other people matter. Let's really focus on mental health. So that's my final quiz goal and summary. I have a couple extra slides. I'm going to say thanks for listening. Please take good care of yourselves. A bonus. Okay. So one bonus here, and then I probably will stop and take some comments and questions. It's so important for us to approach everyone with respect and empathy. To take it deeper, like when Kelsey and I were talking, where we really work to see other people. One thing I like about choice theory and reality therapy is that they emphasize that, like, if you work in a school and you're a teacher or you're a principal, you should make eye contact or some kind of contact and welcome everyone individually into the community of the school. And that that's what helps people feel like they belong. But like most things in choice theory and reality therapy, that's also a little bit superficial. And so I hope you can take it deeper and not just see people, but see their gifts that they bring to relationship and community. We want to consider suicidality as an expression of pain. We want to emphasize belongingness, help people feel included, help everyone feel useful, as if their life has purpose. And then the last thing is something I didn't mention, but this is a fantastic quote and it captures a ton. It's stress accumulates, opportunity ameliorates. This was by a guy named James Garbarino in 1986. We know stress piles up, right? And you guys all know this in your lives, right? You get stress. I mean, you're probably heading toward the end of your semester, so you're feeling really stressed, right? And it's piling up and piling up. One thing, I mean, obviously, good self-care helps. But when we think about communities, we think about couples, we think about families, we think about individuals, opportunities to engage in art, opportunities to engage in theater, opportunities to engage in yoga, opportunities to engage in social justice clubs, opportunities to engage in religious groups. Those opportunities will help ameliorate and cushion us from the stresses that we are inevitably going to experience over and over again. All right. I have a double bonus here, but I'm going to break out because I always like to have some extra slides in case I'm super fast. Anyone? Questions, comments, reflections, arguments?
I think earlier you had mentioned, and I think this is what you and Kelsey were discussing about how like TikTok has influenced that a lot. And I probably should have mentioned this earlier, but I have seen that in my site too. There's this case that my supervisor deals with, and it's like the girl thinks she also has the multiple personalities.
Mhm.
And we obviously you can't just disagree with her, right?
Right,
But
right.
we have like came to the conclusion of like we feel like it's more of like the social influence of it. And overall, like I feel like it's hard. Like how do you think we should navigate like social influence, especially social media, going into like suicide and stuff? Because I feel like yes, it's normalized, but it's normalized too much that people are like, it's not that big of a deal.
Yeah. So is it pronounced Lisvit?
It's Lisbeth.
Lisbeth. Okay. Well, thank you. Well, I'm affirmed by you having a similar experience with someone who is using TikTok for some self-diagnosis and inaccurately using it. And I love everything you said because we are in a bit of a predicament. How do you navigate that? And my answer will be very carefully, because just as you said, my impulse sometimes, and I have done this from time to time and it never works, is to say, hey, you know what? I've studied a long time and I'm kind of an expert at this, and you actually don't meet the diagnostic criteria, and never works. Never works. I'm sharing that because I've made mistakes. And I think the purpose of some of my mistakes is to inform others to never make them again. So we can't really argue with them. I think what we do instead is we do the deconstruction of the category, the mental disorder category, and try to make it very individualized, like what's happening for you. What does that mean? And maybe explain to them an sort of a different thing that's related to labeling, but sort of is a little bit confusing maybe. But it's like whenever we do labeling, we don't treat dissociative identity disorder. We don't treat depression. We treat the symptoms of dissociative identity disorder. We treat the symptoms of depression. And so sometimes in a collaborative way, what I would recommend is that we sort of identify the individual ways in which the person is experiencing distress or disability or dysfunction, right? And then we start there, because and really even tell them the bigger diagnosis is really not that helpful to most of our treatments, because we want to work with you as a unique individual. Even if you do have dissociative identity disorder or you do have clinical depression, I still want to work with you and your own unique way of experiencing it in the world. So that's one way I would try to kind of move around the issue. I'd also be open to your ideas and everyone else's, because this is a precarious predicament for us to be in, with people who come in, especially young people, but older people too, who have completely self-diagnosed. They're very confident that they know what's wrong with them.
I think, well, for me, what I think has helped is listening to what they have to say, but also like shifting focus and not making it like, yes, you're right, everything you're saying, you're so correct, like this is what you have. Because then it like dwells on people and they become the disorder to an extent.
Yeah.
Like it's just like
Yeah.
stay focused. I don't know what anybody else thinks.
The words you just used, that they become the disorder, is, I think, very insightful, because we know that labeling is very sticky, and that people get labeled with a mental disorder. And this is one of my concerns with early suicide and depression screening in schools, is that kids get identified and then they identify with the label. It becomes who they are. And and this is in some ways especially ridiculous, because even among professionals, the DSM is a pretty low reliability instrument in terms of diagnostic reliability, is just not very good. And so if 5 of us did a diagnostic evaluation of this person who thinks they have dissociative identity disorder, we'd probably have 5 different diagnoses. And so the fact that they get so sticky and they become part of someone's identity is really kind of ironic, in that they are really pretty loose terms and they come and go. Now, there are exceptions, right? When the more severe diagnostic categories, schizophrenia, extreme bipolar disorder, those kinds of things are entities, and that they tend to be chronic. But depression, not so much. Anxiety, these things are not necessarily chronic conditions. They respond pretty well to treatment. And sometimes the diagnosis are just completely wrong. So I like your approach. Other thoughts about TikTok, self-diagnosis, anything else?
I was thinking a little bit about how this pertains to, I guess, availability bias, just because we have, case that I have seen personally, because I'm doing a practicum right now in a behavioral hospital, and I see a lot of my patients just come in and automatically think that they have autism, because that's something that's so huge on TikTok right now. And they're like, I'm very awkward. I never really got along with people, so I must have autism. So I completely agree with just treating their symptoms rather than, and I guess enabling that idea and just being like, yeah, you do have autism, because
Yeah.
you probably don't, because they don't
Yeah.
really fall under all of the diagnostic criteria. So,
Right.
yeah,
Yeah. Oh, it's such a great example, because autism has become incredibly, I use the word popular. And I think maybe one of my new philosophies, because I'm an old curmudgeon, cranky person who thinks that my opinions are really good, I'm trying to be more yes and, like, oh, yes, and what's your unique way of experiencing that? Because that's going to be much more helpful for me to find out what their experience is, and then to help them with those symptoms and those issues. Yeah. And, another thing I would say that we can do, and I reluctantly say this, is get on TikTok and make our own corrective videos about diagnosis, and about cautioning against this sort of perpetual identification of what's wrong with us via bad information. The Montana Happiness Project has, I've got this one high school student who creates TikTok videos for us, and we don't get much traction at all. But I pay her $20 per TikTok video, and I think she's quite happy. It's her first social media income stream. So, I know it's almost 10 till. I know you're going to have a short break and then you have another presenter, but let me just say in closing that I have a blog, johnsommersflanagan.com. Most of the things that I talk about are on there and free. Obviously I have books and stuff like that, but I also have so much free stuff that you could keep yourself busy all day just looking at the free stuff. And we also have the Montana Happiness Project, which is another website with resources on that. We have a Montana Happiness Challenge. If you look through that, there are 15 or 16 different specific positive psychology assignments that you can use yourselves and or that you could use with your clients. And yeah, so I appreciate that you all are just here being flexible with our time issues this morning. And yeah, Dr. I.
Yeah, I just want to take the time to appreciate you. I want to be real intentional about that too. I want to thank you for just all of the wonderful resources. It was a very thought-provoking presentation. I'm probably going to be thinking about it for a long time. And I'm going to, check back on my presuppositions about, suicide assessment. This was great. So I'll be thinking a lot about it, and it really raised a lot of awareness of things, just so that, we can just be better at recognizing really how to help people, and not always just jump to conclusions or also fall back on any guilt if we miss anything. There's so many things I think to reflect on with this. And so we are recording this, so we're gonna, I invite everybody to go back and watch it. But it was really, really helpful. So thank you so much. And thank you for sharing about your resources. I'm going to visit your blog. So thank you all so much for everything. And thank you all for being here and being patient with us. And so yeah, everybody, now we can go ahead and take a short break. And then we will come back around noontime, and we'll have our next presentation. Thank you.
Thanks, everyone.
You.
Thanks, Dr. I.
Thank you.
Yeah, Suzette, we have the slides available. We'll send everyone both presenters' presentations when at the end of the day.
Perfect. Thank you.
Okay.
Yeah.
Wow, let's pull that up.
All right. Whenever y'all want to get started, you can.
Okay. All right. Does that look good on y'all's end? Nice. Well, thanks again for having us again to talk about this topic we're both passionate about. We'll both introduce ourselves in a minute here. Katie, as you can see, I did see that it's like 80 degrees in Corpus Christi right now at the Island University. It's about 70 here in Asheville, just for context. But I think y'all are going to get more wind today. So I always love pulling up pictures of your campus. It's gorgeous.
Thank you.
And Katie's driving, so I'll let her just flip when she's ready. Ultimately, what we're hoping to do is to understand some of the core principles of integrated care, and then also talk about what are some strategies to use in order to be effective in working with medical professions and best help clients in that manner. And then also some kind of evidence-based techniques or assessment methods that we might be able to use. So we'll be talking kind of broadly, and then also kind of getting into the minutia of certain different instruments, such as like the PHQ-9 or the GAD-7 and others that we'll be talking about. So that's what we hope to accomplish. And a little bit about me. I'm a professor. This is my 25th year at Western Carolina University. Dad, husband, brother, dog dad. You can barely see Chato and Mila here. But this is kind of my education, and just like to keep in mind so that you know who I am. Cisgender 59-year-old, first-gen college student, and I'm a little scattered, but one of my goals is to kind of help increase awareness about systemic psychopathy as well as positive psychotherapy, but there's a lot of other things as well. Now, I did add some other personal stuff here, Gen X, INTJ, Pisces, Enneagram, Hufflepuff, and I do that, A, for fun, but also to make you aware that I think the more we know about ourselves, the more present we can be, the more self-understanding, which then allows us to be open with clients, and also a curiosity to get to know who they are. And I think that curiosity itself is healing. So that would be one advice I would have for all graduate students, is to learn as much as you can about yourself. I think that makes you more aware and appreciative of others. And I did want to make you aware that the QR code here is to this presentation, which I uploaded into Notebook LM and created a podcast out of, and then loaded it to my YouTube channel. It's about 20 minutes long. So all this information, and they did a good job of kind of summarizing. I know you're probably thinking like, why would I listen to a 2-hour lecture if I can listen to a 20-minute podcast? So it might be a good refresher. And by the way, if you pull that up, the voices on there are AI. It blows me away every time, but it is from these notes. So check it out when you get a chance, but you'll have a resource when we finish today.
Awesome. And I'm Katie. I'm so glad to be here. I noticed you updated my age, Russ, since it got higher since we last did this. So thank you for that.
Yeah.
Yeah, but I am the youngest of 4 sisters. And so I have learned to sit back and listen and wait for the moment where I can step in. And that has served me well in integrated care. I also play on what is now the old ladies soccer team. It didn't used to be the old ladies soccer team in the league, that have been a soccer player for a long time. And I always share that I think that's where my roots of integrated care came from, because we used to be told you're not a position, you're a player. And that was my job, was to get the ball to people who could do more things with it. And that also has felt like my journey in integrated care, is how do you be on this team and make sure everybody feels value and get that ball to people who can do a few more things in it than I can. But just really glad to be here, and just share a little bit about what integrated care has looked like in the settings that I've been in.
Yeah, and that's a good point to mention. When I worked in mental health, it was in South Carolina, and we had a comprehensive mental health center. So I worked alongside psychiatrists, nurses, psychologists, social workers, marriage and family therapists, counselors, of course. And that gave me an understanding of the need for integrated care. So our psychiatrists were always good at taking blood pressure, checking heart rates, and doing that type of thing. And I even had an incident to where a client of mine with schizophrenia and also in remission, but had alcohol issues in the past, came in. It looked like it might have been a relapse with schizophrenia and potentially hearing voices, maybe other hallucinations. And it wound up not being, because the psychiatrist took his blood pressure, checked pulse rate, did some other medical kind of things, and realized that he was very dehydrated. There may have been something else involved, but instead of him being sent to being committed, he was actually sent to the emergency room, and they helped him get everything that he needed, and he was fine. And so that always has made a significant impact on me, that this could be a situation where somebody was sent and treated and not getting the appropriate treatment. And for the last 25 years, I've been supervising a lot, and as field placement coordinator, linking our students up in integrated care settings and supervising. So I've got that kind of unique lens of seeing how students kind of navigate these waters. So today we are going to be thinking about what are the mindset skills we need, as well as the clinical skills. I think you'll get a feel for that. Like if I were y'all and you were taking notes, I might put mindset, clinical, and maybe just kind of jot notes and let us know in the chat if anything's unclear. I am going to work hard at keeping an eye on chat, but since we're trading slides, Katie, maybe we can team up and do that.
Yeah, sounds great.
All right. Yeah. So I asked chat. I asked chat to come up with a nice intro into why this is important. I'm not going to read it word for word, but I'll give you the gist of this is that I think as mental health professionals, we do need to have an understanding of how to work well with all different kinds of professionals. And that way we can make sure that clients are getting their best needs met. I think in this introduction, what is kind of being said is that, hey, a client could come to you with anxiety, but also have blood sugar issues, thyroid issues, and so forth. And we could do all the counseling possible with this person and still not help the situation. It's also mentioned, and this is something that I've heard throughout, is that folks with severe and persistent mental illness have significantly less lifespan due to medical conditions that are not being treated, or metabolic syndrome with the heart. Well, the medicines to treat schizophrenia and other severe and persistent mental illness types of things are hard on the systems, on the liver and kidneys and so forth. So we need to be kind of busting up the silos here and working together. So that's kind of the point of this slide, is just recognize that this is important stuff. And in order to best serve clients, we need to be collaborating together. Just as a reminder that the CACREP standards now in the 2024 is that students will learn how to work in collaborative care settings. We do have a video that can be streamed here that we did years ago that I think it still holds up. And in fact, I'm pretty sure there's Oscar buzz with my performance. I don't like to brag, but it's, yeah, probably some Oscar buzz here in the future. But just know that we've got actual demonstrations of what this looks like. And your self-care and ability to be present in the moment is the key. You are the unique vehicle. Nobody can do what you do with your unique personality, your unique upbringings, all the hardships that you've experienced has created a resilience, created a unique perspective, but we got to be present for that to be able to bubble up. And that is what's going to help clients, help us connect with clients. Also, and we're going to talk more about this, is as a counselor in an integrated care setting, you're using your counseling skills with everybody that you're working with physicians, with nurses, administrators. You're not counseling them, but you're using your good assessment skills, your good rapport building skills, and that's going to be important. If you get into an integrated care setting and you're just thinking you're going to be working with clients, it's going to be a tough road. You're going to need to make sure that you're building rapport and using all those good skills with everybody. In order to do that well and allow your true, beautiful self to shine, you need to be present. So this is just an acronym that I would encourage us to kind of think about. It's something I think about regularly, just to make sure it's like, hey, am I here right now? Or I am spinning off about what I'm worried about, or in the past of what I regret. And we know from research that you can access more of your full cognitive potential, and particularly your working memory, if you're right here in the moment. Anxiety and regret actually use up working memory. And if you think back to your assessment class, working memory is one of the chief components of your IQ, of how we determine IQ. It's really critical. So when we're actually present and in the moment, we're actually able to access our full potential and then be present with clients.
All right. So what we see here, the comprehensive healthcare integration framework, is really simply like what makes successful integration. And there's these domains that say, hey, this is what we're paying attention to. This is what we know can be really helpful. So you see number one, screening and referral, but really are there patient registries where we really know who the people are out there that we really need to follow up on? And do we have some agreements on how we identify who patients are and how we follow them? Number two is going to be all your evidence-based guidelines. How are we identifying risks, or are we screening everyone before we would prescribe an opiate? And just really paying attention to how these risks are identified and what protocols we're using in integrated care. Number three is really how do we track this follow-up care? So this is like care coordination. Yes, we prescribe the medication we think's best, but how do we know if this person took it? How do we know that they have access to it? Really being proactive versus just waiting to see down the road how someone's doing. Number four, just really thinking about the culturally appropriate interventions that we're using with family. So is the materials we have in the language that people read, right? Is it accessible to them? Is it at a level that's accessible to them? Or maybe it's about using apps that people can track for themselves how they're doing. But really, how can we give more power to the client or the patient and being able to take their health into their own hands in a way that really fits for who they are and how they walk through the world? And then you'll see these other domains here that have to do with the care team, which is really, does the team itself get training on how to be a team and how to work together? Do they have regular staffings where they're really talking about somebody who might be really complex? Are there huddles or annual trainings where they're really seeing themselves as this integrated care work that we do is really unique, and we know some things about how to do it in a way that works best? What metrics are we using to really see that we're providing quality care? So this is really around whether it's population management or just QI projects. What are we targeting and how do we know if we're getting there? And is there often a champion of someone who that's their job on the team to really be looking at that? Another domain is really, you see that social work stuff that all of us do. Are there arrangements to really make referrals to the local domestic violence agency, but also to know if the person got that? Are we following up to find out if people are able to use some of our other agencies around our clinic? And then you see sustainable billing. So really moving from, what can we do? What can we be allowed to bill for? But just what does this really person need? And can the clinic really provide support in a way that supports populations and people? And there are some models out there that you really can just, everybody gets paid per patient. So we know we can take care of them the best we can.
And I wanted to mention, since it was on that slide about immigration support, I've made contact with somebody and had him as a guest speaker who was in, oh my gosh, Portland, Oregon, who's working with an attorney. And she's a social worker, but she's doing the initial interviews with folks who are seeking asylum for various reasons. I forget all the different asylum categories. And then making recommendations, and then the attorney takes it from there. And this seems to be kind of a newer specialty so as the graduate students, that may be something that you would want to look into. I had not heard of that, and it seems like very interesting and meaningful work, and maybe particularly now in our kind of current culture, being able to make sure that people need the safety can get that being in the U.S. A couple terms, again, this may be more mindset stuff, again, if you're keeping columns and notes, but when we talk about evidence-based practices, clearly the therapeutic relationship is probably the single best determinant of outcome for clients. So all the good person-centered, existential skills, all the humanist types of theories you learn about. Relational cultural would clearly fit in there. I would say feminist therapy as well. Cognitive behavioral therapy, again, a lot of evidence supporting its efficacy if done well, and nuanced with what the client needs. But I also want to introduce kind of practice-based evidence. And I think this fits within integrated care because what we were doing is collaborating closely with the client, finding out what works for them, making adjustments throughout the process, and keeping in good touch with the client. So they're not being treated, they've got a collaborative partner And yes, you have expertise, but you need the client's input and discussion and so forth in order to make it work best for them. So when we talk about practice-based evidence, I think it is less medical model, even though we want to be able to be really effective within kind of the medical setting, but we're going to really emphasize collaboration with the client. We're going to talk more about that as we go on too. And just the continuum of behavioral health, I would argue that we are all doing some type of integrated care, even if you are in a sole private practice. Your clients are coming to you not just with anxiety and depression, but also with some medical issues, whether it could be diabetes or, again, thyroid issues, anemia, different types of things. And there is, this was in Counseling Today a while back, Nancy Wheeler talked about there was an unfortunate incident to where a client, I believe it may have resulted in suicide, and there was, the lawsuit said that the doc, the medical doc and the counselor should have been in collaboration to some extent. So I don't know a lot about the details of that case. However, it sets precedent to where there could be potential lawsuits if you're not getting signed permission so that there could potentially be collaboration between the medical doc and you or providers. Co-located, this could be a situation to where you share an office with medical providers, but you're not necessarily fully integrated with them. They refer people to you, but you wouldn't necessarily get called to visit a client in the exam room. And fully integrated would that be that type of a setting. And MAHEC, where it's the place where we place students here, is a fully integrated system where the docs will ask our behavioral health professionals to come into the exam room and maybe do some brief types of treatments. We're going to talk some about the acronyms for substance abuse and different types of maybe smoking cessation and so forth. So that would be fully integrated. Models of integration targeted would be if we're really focusing on treating people with diabetes, because we know that mental health issues affects diabetes. So I don't know if I'm saying that weird. It sounded weird to me, diabetes. Anyway, so that's where target is, like we're really being specific about what we're focusing on. We want to make sure people with diabetes are getting the type of care they need. Non-targeted would be more general. You might see this in an integrated family practice. And we're going to make sure that we're treating everybody, of course, different age ranges, and everybody gets a screening at the beginning for like the PHQ-9 for depression. When I go to my physician's office, I do the PHQ-9 each time. I think it would also be wise if they had me do the GAD-7 for anxiety, maybe even the CAGE for substance abuse, but at least they're doing that screening. And he looks at it. You know, I see my physician looking at it, and fortunately I'm okay at this point, but I'm sure he would mention something because they know that untreated depression complicates everything in your medical care. And then reverse integration is what Katie experienced in her clinical mental health center in Waynesville, to where they actually had a physician come in 2 days a week to the mental health center, and then they collaborated in that regard. And I'm sure Katie's going to talk more about that. So there's just different types of integration, but I would argue that regardless of your setting, you're doing integrated care, and there's potential for lawsuit if you're not kind of keeping an eye on that and asking clients about their medical care and issues. Okay, Katie, we're ready for the next one. I did, you know, one thing where integrated care gets dinged is that we're not talking enough about positive psychotherapy. And I know that John Sommers-Flanagan did that and has that beautiful PowerPoint. So I was really happy to see that. And it's not surprising because I've always followed John because he always seemed to be on the leading edge of behavioral health. But I did want to mention that when we look at the longitudinal study on happiness, I believe this was in Harvard did this. I think it's important for us to keep in mind that we're not just trying to reduce symptoms. We're also trying to increase somebody's quality of life and their ability to thrive. So from a mindset perspective, that would be a note I would want to take, is that this is not just about reducing, it's about increasing people's quality. Here are some results they had in a longitudinal study of happiness. The results were the folks that were the happiest in later life did not smoke or quit and reduce use of alcohol. There's been a lot of complicated research with alcohol, and ultimately what I'm hearing now is that alcohol is a neurotoxin. It's not healthy. Where it's gotten complicated is that a lot of times people are using alcohol in social settings, and being social is good for your quality of life. So that's where you see it getting kind of convoluted. But alcohol itself, if you're ultimately for happiness, it'd be good for you to quit or reduce the amount of alcohol. Healthy body weight. Now that comes from the medical world. I don't know a lot about it. Of course, we don't want to be body shaming in any way, but from the medical world, folks that were more in the range of healthy body weight were happier later in life, as well as those that exercise, had coping skills. That's kind of broad, and I don't know the definitions that they put there. Education, I guess that was higher education, and then a stable long-term relationship. Those were some of the factors related to happiness later in life. So ultimately, let's just keep in mind that we're not just trying to reduce stuff. We want to increase people's ability to thrive through the lifespan. This is recent, and I don't think it's going to be mind-blowing, but the discovery of the Somatic Cognitive Action Network. And ultimately what this is saying is now they know why they didn't specifically mention counseling, but they do talk about like vagus nerve stimulation, exercise, breath work. They know exactly now where in the brain that is actually helping the body. So I think this is the kind of stuff that's helpful if I'm a counselor and I'm going to be working with medical professionals, to kind of have this and be able to say, hey, now we know this, so we know how important it is. It's not something esoteric. It's literally a portion. We can find this, within our neurology of where these interventions actually do help the body. So I think that, Katie, did you want to share any more about this? I know we've discussed it. And I love this. And in fact, I got some more data I'll share with you, but that counseling reduces healthcare costs. So if you are looking at going into integrated care or maybe establishing a site, this is kind of the important information. Saving money is something that gets people's attention. It gets lawmakers' attention. It gets business owners' attention. It gets grant funding agencies' attention. This was a German study, I believe, large sample, 22,000. And what they did is they looked at medical costs 1 year prior to psychotherapy and then 1 year after. And what they found was after less work disability days, less hospitalizations, those are very expensive. When I worked in mental health, that was my job, essentially, was to help reduce the amount of hospitalizations our clients had. And hopefully I did a decent job of that, because hospitalizations at that time were about $1,000 a day. So if we can reduce that significantly, that adds up. And inpatient costs. They did find that it increased medication costs a little bit. That makes sense. Somebody who wasn't getting treatment may find that they need an SSRI medication for depression or anxiety, maybe OCD. And then so we get a little increase there, but that keeps them from more of these expensive things. And I was really interested. This is something I've been interested in for a long time. I did admittedly go to chat with this, but I checked out the references they use. You definitely want to do that if you're using AI, because I have had some hallucination within AI. And I realized we may need to change that term, but that is a common term used with AI. Maybe out of fairness to people who experience hallucinations, but we want to make sure they're not giving us errant information. I did check this. But my interest was what's the estimated lives saved by counselors? And I just had no idea of how to go about that. AI with all its capabilities was, I think, helpful here. And ultimately what it came down to, by looking at research related to when people get counseling, there seems to be a reduction in suicidal behaviors. And I'm sure that could be argued, because I know in John Sommers-Flanagan, there was, some probably contradiction to that. However, based on this, what it looked at, I'm going down to the bottom, is that if you are seeing 20 clients per week for 50 weeks for a career of 20 years, based on this estimate, which again is a rough estimate, it would be a reduction in, you would save potentially 2.6 to 5.2 lives. Now, who knows? Who knows here? But what I would also say is, I shared this with a couple of our, what I consider master therapists that I know in the area. And one of them did email back saying that she knew of 3 people that came to her with specific plans that are still alive today. So at least anecdotally, but this does not touch on just the lives changed by counselors. Now, the reason I wanted to share that today is what you're doing as a counselor and a behavioral health professional is important. It makes a difference out there. Maybe it does save lives, maybe it reduces suicides, but it definitely changes lives with the work you're doing. So that's something I hear regularly. Yeah, I'm a little surprised I'm not seeing more research out on integrated care specifically. But this is kind of like broadly just some stuff that you're hearing kind of overall: improve access to care, especially for children, improving client satisfaction with care. And I've heard anecdotal evidence of that clients would not seek behavioral health therapy or counseling unless their doctor had recommended it. And it made it so much easier when the doctor recommended it to somebody who's actually in their office. And I know one woman was talking about, the reason I started counseling is my doctor recommended it. The client was actually the counselor was in the office. I knew where to park. I knew the front office staff. I didn't have to be scared by all that change and going to a new location and not knowing what to do. So those are some of the support or evidence supporting integrated care. And then, of course, this good one in Texas with another good UNC Greensboro graduate that leading the study here, but significant improvement in quality of life of severe and persistent mental illness clients when they're getting integrated care versus treatment as usual. And I suspect this is kind of just because with severe and persistent mental illness, there's untreated medical conditions and the medication is very hard on the body. So if we can be looking at both simultaneously, we're going to do a better job of providing quality care. Yeah, this is a study too. I just wanted to, and this was not published. This was from a PowerPoint and a presentation given that was shared with me. But it might be something as a graduate student and thinking about integrated care and talking with medical providers that what they found here was that by having a behavioral health provider intern 1 day a week, it actually created over $1,100 in revenue, which comes up to $58,000 in a year. And the way it created that revenue is it freed up the medical providers so that they could see more clients or patients in the day. And so when they had somebody who was dealing with depression or anxiety, they could refer to the intern who could work with them and teach coping skills and so forth. Medical providers see more clients more, and then that's what created revenue. So I think that's unique. I would love to see this study duplicated. But that's the one thing I would keep in mind if I was trying to sell folks on this, is that it could wind up, saving money and creating money, actually. I will not go into all the numbers, but I'm going to give you the gist of this. Now, this was a graduate student of ours. He is successful in private practice right now in the Asheville area. His father died of a heart attack yes, okay. And then the son, the student I was talking about, went to undergraduate and essentially started having chest pains, rapid breathing, all that. It made perfect sense. They would go to the ER, that they would check out, that they would do all the different type of medical imaging. He's got a family history of heart disease, so it makes sense that they did that. The unfortunate piece of this is that, and this is him, memory is not always the greatest thing, we know this, but he says he was never asked about anxiety through all the different rounds of workups, medical workups that were done. And it did wind up being panic disorder. So once he got diagnosed and he was able to get treatment, probably some medication as well, and he's again doing well today, which I'm happy to say. But I suspect some of these tests were very needed, but probably not all of them, had he been screened for anxiety at the get-go. Another reason we need good integrated care professionals. All right. And so just keeping in mind that in this revision of the Hippocratic Oath is that they are taking into consideration that warmth and sympathy and understanding may outweigh the surgeon's knife or the chemist's drugs. And I think that's kind of the crux of what we're talking about today is that we need good behavioral health professionals that can get to know clients, that can perhaps spend a little more time with them than the medical providers can, so that people feel valued. And then they're even at the very least willing to kind of follow doctors' recommendations for diet and medication usage and so forth. Again, another mindset thing. This was a study, I believe it was a French study in 2003. I suspect we're going to see a lot more of these. But that you are, as a counselor, a specialized healthcare provider. And we know that what you're doing through your talk therapy, no matter what modality you might be using, whether it's solution focused or CBT or person centered, is that it's actually changing and helping at a physiological level. And I think the more studies we can do like this to where we can actually show folks, but this was a simple example, somebody with a spider phobia. And then after cognitive behavioral therapy treatment, we're seeing that that prefrontal cortex area where the fear was lighting up is not lighting up as much. Okay, so I suspect, and I don't know neurology that well, but I suspect through CBT, we're able to bring in kind of more rational assessment. And then that's helping to calm down the amygdala a bit with practice, of course. So your specialized healthcare providers, and that's something to keep in mind because it can feel intimidating when working with medical professionals, or if you're watching, you know, all the like The Pit or dang, what is that one you watch, Katie? Focus or Pulse? Is it Pulse? Yeah.
Pulse, yeah.
I mean, they're going so fast and they're saying all this kind of stuff. You can feel overwhelmed, but I want you to stand in your power and into the training that you're getting, that you are specialized healthcare providers and you got something to offer. Nadine Burke, last I heard, she was something big, Surgeon General of California. But anyway, I love this as a medical provider, and she worked in the Oakland area for a long time. She goes, hey, this would be a part of my treatment plan if I had it to offer, is that I've got this person who's been exposed to drugs in utero, had domestic violence in their background, or the mom did. And so let's start with biofeedback therapy as well as insight-oriented type therapy. I suspect we're going to hear more about that. And then keeping in mind, let's see, we're doing good with time. Let's see. Keeping in mind that as a there's a lot I want to say here, so let me just get focused. You are going to be a generalist, and you're going to need to really kind of wear a lot of hats as a behavioral health provider. I'm just going to say counselor, as a counselor within medical settings. So as a generalist, you're going to work with a lot of issues. You're going to need to know good evidence-based treatments for anxiety and depression, trauma, and addiction issues. You need to be accessible, so you're not just kind of holed up in your office waiting for people to bring you clients. You need to be out and about. Team-based, clearly you're working with all the different professionals, and you're probably going to be, the high volume is you're going to be working with brief sessions, maybe like 20-minute meetings with a client to teach some skills, find out how they're doing, follow up perhaps by phone. I know that Mayheck would do that. You're going to be doing some education with clients and with the team. And you're just a part of the fabric of the practice. You're a routine part of the practice, and people know they can call on you. And that's why it's so important for you to get to know the front office staff and everybody so that they can trust you, they know you, they see you around, and they feel comfortable calling on you. These are some of the glam products I'm using today. I usually get a lot of comments about that. And if you want me to do a tutorial at the end, just put something in the chat. I'll do that.
Right. So we just wanted to give you a couple of examples of what integrated care can look like. Sometimes it is thinking about a full healthcare clinic, right? A doctor's office, or where there are clinicians added and everybody's on the same page, but sometimes it's not that way. This was a site that I worked in North Carolina, where the funding we got first, we tried to add clinicians into clinics, and the clinics that we approached said, we're too busy for that. So just telling you the real deal of what happens out there. We can't add therapists here, we're too busy. So instead, we did what Russ mentioned is called reverse integrated care, which was we added a physician to the mental health agency. And our primary population in this one building in Western North Carolina was persistent mental illness. Those are the folks that we saw. That's where they went. And we were able to add a physician and a peer support specialist. And they really were part of that team. So we took a picture of the team. It had a clinician, it had the physician, it had the nurse, it had a person that did a little bit of case management, and it had this peer support specialist. So everybody would get a picture of the team just printed for 5 cents at CVS. And hopefully you could meet everybody on the team, or you might circle the face with a permanent marker. But the idea was, this isn't odd. When people go to the doctor, they're kind of used to there being different rooms and different people. And so on this team, it was like, oh, and here's your peer support. And that peer was just explained to like the person that helps you with whatever goals you're working on. And that peer could really explore their strengths, but also what was getting in the way. And the peer that worked with us, who was fantastic, she had lived experience in chronic pain and her own experience of depression, some really debilitating depression. So she got it. And sometimes she shared her story when it made sense, and sometimes she didn't need to. But really focusing on the relationship and focusing on where is this person in stage of change. So maybe they do have an insulin thing that's really out of control, but actually they're not that invested in changing it, that they would really meet them where they are. And they were doing phone check-ins, going to the grocery store together, not always in a like, we're going to go and buy you everything healthy, like you see in this cart, you only see green. But sometimes it was just to be with them over time so they could start to feel what is their day-to-day, what gets in the way. Maybe they don't have a way to cook. Maybe they have no idea how to cook things or what certain things are. And then they were always like, hey, I see you've got an appointment next week. Do you need a ride? So hard to remember what time it is. Do you remember what time it is? And just really being that support to help somebody get to that appointment at the place that felt safest for them. So the clients that came here that had persistent mental illness often had trouble getting to the doctor's office, so they didn't go, or they had been fired by a lot of physicians for things, the way they showed up, or missing 2 appointments, or not following their treatment, things like that. And so it was really about going to where they were in this particular clinic. And then here's just another example. We were involved where a clinician was added to a health practice where in 1 year, several of the doctors had retired. And it was discovered that many patients were on high amounts of benzodiazepines and also being prescribed an opiate. So what we know about benzos and opiates, so pain medication and benzos, is they can be a deadly combination, and people want to be really careful with that. And so we added a clinician at this site where the doctor was really just, having this conversation with patients about like, we can no longer prescribe this, or here's the plan. So of course the doctor's deciding that, but the clinician was able to be there and be a support and then offer some individual and group support later. And this particular clinician was trained in EMDR, and they did that. And the patient started calling him the human benzo, which I thought was like the best compliment of a counselor ever. If somebody feels like their stress went down that far, right? But in that clinic, they really were targeting a particular group of patients that were struggling because they were on these two types of medications. Okay. And then this is a picture you see of a bunch of candy. So we had the chance to put 5 clinicians into 5 different practices, like a regular doctor office practice. And when we started that journey, I thought, this is going to be great. We're all going to do it the same way at these 5 different doctor's offices around Western North Carolina, and everyone will be on board. And of course, that's not really how things play out. But each clinic did something different. And I really say that to think about what Russ said about, like, we're always doing integrated care. So wherever you are, you can start where that environment is open. So on one place, they added a clinician, and really every doctor in that practice or prescriber started just sitting that clinician like what they considered their most problematic patient. Like, who's the person that takes up all my time? Who's the person that's in crisis? Who has all this mental health stuff? Or who did they perceive as was really just struggling with loneliness, and they kept coming back to the doctor's office? Like, that's how they started really that clinician getting people to see and building trust with the team. There was another practice where it really was more integrated. They would have short sessions, about 20-minute sessions. They were following the doctor, so they would go into the exam room. Once the doctor's done the appointment, the doctor would do a warm handoff, the doctor would leave, and they would have about 20 minutes with that patient to do follow-up. And they would kind of know, oh, he said you were working on sleep. Hey, what have you tried before? And might do some brief solution-based therapy to try to help them with sleep. And that clinic worked that way. There was another clinic where it was a pediatric clinic, and they were overwhelmed with requests for ADHD assessments. Like, that clinic was like, we'd never be able to catch up and to really do a good job of doing that. So they really targeted that, and that counselor would really work with the parent and the school to help get these assessments done, to really rule out, were there other big transitions going on? Was there trauma before we jump right into medication? What's been tried? And really support the family along the way with behavioral interventions as the provider would make the decisions about medications and move forward. But just to give you a few examples, that not all clinics will look alike. And so it may be that you just start where you are and start with what's important as you build trust with the practice that someone might be at. And then just go ahead. Yeah, go ahead.
Is this you? I'm sorry.
Nope, you jump right in. I think it is you.
I think you can add whatever you like. I just want to say I'm surprised only Lena wants to see a Get Ready With Me video. And all right, I don't know what I'm doing here, Katie. If it's not about sharing beauty secrets, I do not.
Hey, stick to the important stuff for sure.
Yeah, yeah. And my Oscar buzz, I mean, come on. Just know that in integrated care, I think we've touched on quite a bit of this, but I did want to, what I ask my students is that they go into settings, and this is regardless with practicum and internship, with humility, gratitude, because if you're a field placement coordinator like me and we're talking people into taking students, please be grateful that they're hosting you. They're usually not paid for hosting you. And so just kind of going in there with humility, gratitude, flexibility, and creativity on how you're going to kind of get your needs met with all the cake rep requirements for field placement and so forth. But I think these things will help, is to recognize that you're going to use the essence of your counseling skills with everybody on the team, not just clients. And honestly, y'all, it's if any of y'all come from a school background, integrated care is very similar to what you're doing as a school counselor, because you're going to be working with administration and teachers and the specialist providers and parents and the students. Same thing in integrated care that helps, is that you're going to be really good at working with everybody. think about what energy you bring to the practice. Is it looking and noting everything that's wrong? Because you're going to find that if that's what you're looking for. There's going to be a lot of stuff that could probably be enhanced or improved. But I recommend spending time listening a lot. And I like this old adage. It may be an old adage, but I think it's served me well in my career, is that my first year on the job is to listen and learn. Even though I might be noticing things that, oh, wow, this could be done better, this could be improvement, listen and learn, get to know people. And what I found in a year is I start to understand why things are the way they are. Not that they don't need to be improved, but I start to get a feel for, oh, this is why we're doing this like this way. So just keep this in mind. We want to kind of bring in that humility and gratitude, build rapport with everybody. And I tell this story every time. Katie's heard it. And this was Russ but I talked with him. He was a provider. And I asked him how things were going in a family care office, and he goes, it's kind of tough. I'm not getting a lot of referrals. I saw him again about a year later, and I was like, how's it going? He's like, man, I'm busting out of the seams. And I said, what changed? He goes, I spent time getting to know the front office staff and everybody in the office. They got to know him, liked him, and then it was easy to get referrals. They're like, hey, this is a good guy. We're going to give you referrals. You're keenly always assessing and figuring out what's the most effective communication strategy, not only with clients, but with staff. And then, yeah, really work hard to see the strength in every person. Katie, I'm going to steal some thunder, but I love this aspect that you had in your clinic of at every staff meeting at the end, you had to talk about a success, a client success, because we are so problem focused that we forget that stuff. And that is a recipe for burnout. And it's also a recipe for, like, if you're like me, you got to work for a living. It's like, wow, I can't quit, but it's just unenjoyable. We understand from positive psych why we focus on the negative. We would not have survived as a species had we been walking out of the cave and saying, oh, what a beautiful sunset, and then the saber-toothed tiger eats us. We had to be on lookout for what was wrong. And those were the folks that survived. And now that's us. That's us. And I suspect we need to really work to build kind of the positive skills. Our fear and depression highways are 4-lane paved highways, and we can get on those quickly. Usually a snap of the finger, we can get on those. Bringing up gratitude, bringing up solutions and stuff like that's more of a weedy path. And we need to be constantly bringing that up, lighten up our neurons, like, oh yeah, I can come up with solutions. I can find ways to get needs met, even in the worst conditions. I can be creative. So keep that in mind. I think that was just a very simple thing that Katie and them did to help remember, like, oh yeah, let's pay attention to the successes we're having too.
Yeah. Thanks, Russ. And one of the things I loved about that is you might have had, or I should just say, you have this physician and you're like, man, I don't think they like me. They never refer anyone. Like, do they like anyone? And now they start talking about one success, and it humanizes them to you and to everyone else. That you're like, oh, these people care a lot and they are overwhelmed and don't feel like they have time. And it just really sets the stage for all of us when we can share those moments. Right. So maybe you're thinking like, I'm not going to work in a clinic. No way, Russ. No way, Katie. You don't have to say it out loud or put it in the chat. But we're always doing this whole person, right? Seeing someone in whole person health. And these are just a couple things I keep in mind about how can we stay curious about people. So in my private practice, these are things that are either in my assessment or that I'm paying attention to. So it might just be things that you ask. How do you think your mental health and physical health are connected? It really helps us know, like, is the person making a connection between these two things? Actually, do they have a pretty good idea of how this is working together or not? Really just asking people if we've left anything out, a piece of them, whether it's like, oh, I didn't tell you I have this hobby. I can remember a client that plays the ukulele. I did not know that. Like, right? But it's a big deal. Like, oh, you have this thing that you do that maybe we can utilize for something else, right? And he was even like, this is kind of random, right? So asking that, just defining what health means together, finding out what is getting in the way of something. I always have this person in my mind. She was a grandmother, and she had 3 grandchildren that she had with her all the time. So she was always carting them around. And come to learn, she could not pick, she had so much trouble picking up medications. And the thought out there was like, she didn't want to follow her treatment plan, right? She's resistant, all these words that happen. But actually, she picks up her medication at a CVS that had a drive-through, and she couldn't go inside with these 3 grandchildren. It was like a lot to go in there and wait. And I've been there. It's down the street from my house. And when you go through this drive-through, what you see is that the post and the building are all scraped up and beat up because everybody that drives through there hits the wall or the post because it's like super old school and very skinny, right? And like that is what was getting in the way of this person getting medications. Right. We can address things like that. You can get medications by mail often. It's more convenient. It was an option. So sometimes there are things getting in the way, whether systemic or just a small thing that if we don't dive in, we can't find out without just asking. And then just really finding out like what's most important to you, because we often find that that's actually not the most important thing. That the clinic is thinking about, and clients get to drive, and sometimes we're often not on the same page and we don't realize it.
Thanks. Yeah, it can be simple stuff that really makes a difference. As long as we're willing to reach out and to feel like we do have the right to be in the practice and that we can help. So to tag with what I've also been talking about, or what we've been talking about, is I think it's helpful to understand the personality of medical providers. Now, this is a gross overgeneralization, but we were looking at this from the 5-factor model. Chad obviously helped with this. Is the 5-factor model, which probably you've taken. This is kind of what for the psychologists in particular hang their hat on in terms of personality. I think there's issues with some of the questions, but it depends on the version you take. But remember that the 5-factor model of personality is based on language. It's not based on theory. So this is why the psychologists really kind of use this as a covariate in a lot of their research. So they ultimately just factor analyze all the words in the dictionary that were related to mental health and behavioral health and personality characteristics, and then came up with this after, paring it down these 5 domains of openness, conscientiousness, extroversion, agreeableness, and neuroticism. And so a potential thing just to kind of keep in mind generally with medical providers, based on research, is that they tend to be openness, moderate to high, conscientiousness high. You would have to be with all the quick decisions and the legal liability with wrong decisions. Extroversion varies, could be introvert, extrovert. Agreeableness high, neuroticism low. And I highlight that because this is another reason behavioral health folks, counselors, should work in their settings, because I suspect if we were to look at counselors' neuroticism, we're probably average, maybe even high, because we're in touch with what anxiety and depression feels like. And hopefully we've got some good skills for coping with it. But if you're working with folks that don't, are not as in tune with that, you're going to be the conscious of the practice that you can help people like, hey, this anxiety is really problematic, not just for the person's physiology, but also for work and relationships and all these things that are important for kind of longitudinal happiness. So again, this is just an overgeneralization, but it's something I would say think about when you're going to be working with medical professionals, that they may see the world very differently from you. Now, this could be potentially some genetics, but also the way they're trained. They're trained to make decisions, to assess and make decisions very quickly. Typically in, say, a primary care office, they're going to spend about 7 minutes with each client. And here we're used to the spacious 50-minute hour. But so they're kind of trained to be very quick, and you almost lose the human in that aspect. So that's why we're there. Some other characteristics of medical providers, I think, to keep in mind, you could argue with any of these. Again, they're overgeneralized, but driven, academically gifted typically to get through kind of medical programs. My doctor, by the way, is a rocket scientist, literally. His undergraduate degree is in aerospace engineering. And I suspect, I haven't had time because I just see him once a year. I suspect if I asked him why he left that and went into the medical, it was to be of service. He probably did not feel like he was being of service or as much service working on rockets and airplanes. Wants to help others, independent thinkers, problem solvers. Now, to where we can kind of sit in the mess and trust the process, they need solutions. So it's like, we need to do this, we need to start this, and so forth. So it's important for us to kind of be aware, like, oh, that's how you're trained. I'm trained a little differently, but I need to find effectively how I work within this system and with you. Likes to learn. I could say a lot. We could spend a lot of time with just the need for constant learning. I know as a grad student, you're always stressed with how much you need to learn, but I'm going to tell you that when you stop that process, that's when you're going to probably find you're a little less satisfied with life, maybe bored. So I'm going to encourage you that we're all lifelong learners, regardless of what we're learning. And also empathetic. I think the medical professions in general are empathetic. They're trained to work very quickly, and there's a lot of legal responsibility if they, misdiagnose or so forth. I don't know if we need, I know that we're kind of racing through. I would love to pause and see if there's any questions about this at this point or any slide. But if not, we can move on. And it can always go in the chat too. We good, Katie? Did you do that on purpose?
I did. Sorry. Habit of connection if people want to talk. It's like putting the clipboard down in integrated care, moving the laptop away. You can do it on Zoom too.
Look at you demonstrating that. It's causing me all kind of anxiety.
Yeah. Yeah. Just trying to model to you, Russ. Keep you going.
Yeah, that's why I have you present with me. Need somebody who's good. All right. All right, language to use with medical staff. Here's what you don't want to use. Katie, you can add stuff too. You don't want to say, well, I just want to be present with this patient. I just want to understand their existential desires, and we're going to do some empty chair work with Gestalt. And so we those are all great things, but in the integrated care setting, we have to be a little bit like that mindset of the medical providers. This is what we're doing and why. And so some of the language, hey, I'm using MI skills, using motivational interviewing to build rapport and to increase motivation. I'm doing some 15-minute brief prescriptive counseling, such as solution focus. Now, solution focus, we'll talk about later, is very deep, I think. I think it's one of the more evolved therapies. But people, when they hear it, they're like, oh, yeah, okay, I get it. I'm like, all right. I'm assessing using standardized assessments, using the 5 A's of smoking cessation. Katie, I think you've got a slide on that one, don't you? Yeah. Using the 6 A's for opioid use reduction. And so again, this is kind of the stuff where the counselor calls you, the medical provider calls you in, says, hey, I've got a patient in exam room 1 is on a high dose of opioids. I suspect or it's potentially that they're abusing. And could you go talk to them? And so we know from a counseling perspective that we want to get to know the person, build rapport, find out about all their life. But from the integrated care perspective, to the extent we can, we want to do that. But we also, in terms of our documentation, need to show kind of specific things that we've talked about. And if we only have 20 minutes, we want to spend that time getting to know the client, but we may also say, and I also use the 6 A's for opioid use reduction. Activities, finding out what the pain inhibits, what normal activities the pain inhibits, and the analgesic effect, like on a scale of 1 to 10, what's your level of pain? What's the level of effectiveness of the opioid? And another thing I'll say just about scaling questions, if I don't bring that up, is scaling questions, when we do those kind of 1 to 10 things that you learned in motivational interviewing or solution focus, is to engage the client's prefrontal cortex. A lot of times they come in very emotion dysregulated. I don't know what part of the brain that is, but what we're wanting to do is bring more balance. So oh, wait a minute, numbers, I'm having to engage this and think about it. So like the number itself may not be important. It gives us some information, but what we're wanting to do is bring more balance to the client's perspective. Adverse reactions, side effects of medication, aberrant behaviors would be any other types of drug seeking. Mood and depression would be affect, and then making sure that we're documenting appropriately, which could also be just something as simple as something that they're signing at the end of the appointment saying, hey, if this medication is lost, a benzo or opioid, it will not be refilled. So that's one that could be common in a primary care practice. And then using AI, I think this is going to be a tool we're going to all have to kind of grapple with. I'm finding that it makes my life easier, but I've got to be really careful about the results that I get. But perhaps creating individualized treatment plans with a collaborated, maybe AI analysis, dependent with client permission, of course. But I think that could be one advantage of using that. I have my students do this, by the way, in my assessment class. Is they're taking such things as the Big Five, the 16 PF. Then they've got a choice. Some are doing like light and dark triad traits and even Enneagram, and having AI write up a summary, and then they have to analyze the summary that AI wrote up. Again, they also have the option of not doing that. I know every once in a while I get a student who's just totally against it. But I think we're going to see more and more. I'm curious as to my hope with AI is that it is going to lead to some medical breakthroughs, that to be able to analyze far more data than individuals can and quickly, that we're going to see that. But I also recognize there's going to be some problems as well. AI is based on what's out in the public domain, and a lot of that is done with kind of the dominant society who has created that information. And so it can be insensitive, and it can very easily create bad information. But man, we could talk a lot more about AI. I've been presenting on it lately at the North Carolina Counseling Association and so forth. So we spend more time with it. Recognize in your first meeting that the spirit of the intake is to be curious and interested in the person. Katie's got some videos on my channel that she does an excellent job demonstrating how to do that well. Because a lot of times, if you're not trained in a counseling program, that intake can be just kind of a rote questions, answer, not even making much eye contact with the person. And I think it can be done well collaboratively. And I think that's healing when we take the time to get to know somebody, find out about their life, education history, legal history, family, dreams, desires, what they want, in case there is an emergency, what would be the best plan? All that stuff I think is healing when we present it in the right way.
Right. So we talked about that there's, particularly to integrated care, but in any setting, there's not enough time, right? But patients still have a story, and we really want to get good at being able to both share that story back with our clients so they can say, yeah, that fits, or oh my gosh, you hear me. But also, if integrated care, often we have to very quickly be able to tell someone what is someone's mental health situation to get this full picture, or what's contributed to this current issue and what keeps it going. And so this is the 4 Ps, and this has been so helpful to me. And when you're doing an assessment, how to quickly look at sort of what's happening with this person. So I won't go through each one, but it really is just thinking about what made the person vulnerable, what triggered the most recent thing or the thing we're paying attention to right now, what perpetuates it, like what keeps it going, what is the things that make this keep happening, and then most importantly, like what strengths or supports does this person already have that we can really use to address this, right? Because the folks in integrated care don't want to hear a really long story about the people that we're sitting with. Like sometimes even if you are starting to talk about their history or childhood trauma, like they're tuning out. And so to be able to very quickly kind of walk through these to get a picture, hey, this is both genetically and they've had some childhood stuff. That's what's going on here. And man, it's just so, it's getting worse right now because they don't have any support and they recently lost their job, so it doesn't cover the medication. But here's what they got going for them. Their sister said they could totally help for the next month, so we can look at some medication. I really need your help. So we want to be able to present this just pretty quickly. And in my private practice, I use a billing platform that also has my medical record, and we just started using AI. And writing assessments often bogs clinicians down, even though in integrated care sites, your assessments can often be shorter, but it really can take a lot of time. And I know I struggle with this because I'm like, everything's important about them, right? They're a whole person, Russ. But I have found AI can be really helpful because it can so quickly generate things back to you and it doesn't take you out of it. You're like, oh, no, I don't like that. Or, oh, wait, that is important. Oh, man, you really nailed that. And pretty quickly, it's like someone wrote your first draft for you, even though you were the human being in the room with the connection. So hopefully you guys are getting a chance to experiment with that. But I'm finding that then I can spend more time with people doing the thing that I really like to do.
Yeah, nice. It's a brave new world out there, and it's interesting. Oh, yeah. Well, in fact, I was even at my vet the other day, and there was a sign on the wall in the exam room saying, "This is being recorded." And so I asked, I was like, "What's being recorded?" They said, "We have AI listening to our appointment so it can organize the notes." I'm like, "Oh, we're in a brave new world." So I started singing a lot. Yeah. This border collie knows how to sing. And they are very smart. But anyway, with developing a treatment plan, and again, as we're talking about, I think AI is going to help with this because the main thing I think about with AI, again, with all the issues that we're going to need to look at, again, of where the information is coming from, is my goal is that counselors can be counselors and spend less time with report writing, treatment planning. Clearly, they're involved in the treatment planning, but all the things that I know our folks would even leave the profession because of all the paperwork. They wanted to be with clients. So I'm hoping that that's going to ease that, but I'm sure there's going to be complications as well. But when doing a treatment plan is recognizing that clients first and that this should be collaborative. Katie's the one who shared collaborative notes with me, but I kind of think I was doing that intuitively. We were billing Medicaid a lot when I was in mental health center, and I made no secrets about kind of the notes I was writing. So I like to think I was somewhat doing that, but now it is like, hey, what did you get from today? What are we going to work on between now and next session? And I think it's just important to keep that in mind because treatment planning can sometimes feel like, well, I get the term treatment is a hierarchical term. And I know we use it in this profession. We need to know how to use it, but it comes from a place of I'm treating you versus collaborating with you in care. I don't know, Katie, does that make sense? Or James or Kelsey? Yeah. I have issues with the term treatment. I think that's why I like the idea of collaboration. Did I get this from, yeah, I did, Tex-CHIP. This was a great video, so I highly recommend it. I've shared it with my class, and that we're always keeping this in consideration. Me as a person of privilege, constantly self-analyzing and assessing my biases. Recognizing that I have unknown things that are not popped up yet, but if I'm present, I can pay attention to those when they do. But that these are important considerations. I have my students, as we're prepping them in the assessment class, practice and report back with the cultural formulation interview, and then figuring out in a long 10-page intake which questions might be most pertinent to include, such as, are there any aspects of your background or identity that make a difference to you, difference to your problem? And have you felt misunderstood by healthcare providers? If so, what can we do now that might alleviate some of that frustration and so that we can be of best service? So as always, keeping this at the forefront and continuing to self-assess is important. And I highly recommend this video. I found it very helpful.
Yeah, this image you see here is actually from George Washington University. And it really is an image to help us look at, like, how does the systemic interfere with the personal? So if we look above ground there, that's often what we see, and it's what we're tasked with, or why someone sent someone to see us, right? Domestic violence, or people that are unhoused, incarceration, mental illness. And it's easy, particularly around health, if you're in integrated care, for people to start blaming the individual and just seeing these things. And we're already good as counselors as looking at what's below the surface, right? That when we look at where someone might live, work, play, love, right, worship, if where they're living, these roots of these trees are saturated in what we see here, right? Poor housing or violence, or all of my income has to go to my housing. And so I don't have a lot left over to sign my kid up for soccer or tutoring. And I don't have a lot left over to pay for babysitting, so they're staying with my newest boyfriend. Right? That is what might be happening for someone. And this is just that picture of social determinants of health, right? And we just want to like keep that visual in mind, that there's often a lot more going on. And I think as counselors, we're already good at that. And I think when I started in integrated care, we had gotten a lot of funding to start planning for integrated care. I was like really overwhelmed. I'm like, oh no, now I've got to learn all about diabetes, and I've got to learn about the endocrine system. Like, I think that's what I thought it was at first. I'm going to have to learn about all these health issues. And I did learn more about some health issues. But I just want to, like what Russ says, like, we already have what we need, right? We have the skills here that folks really need, because most of these health issues, as we know, that affect people's lives are connected to stress. And a lot of what supports someone in working on their health is about connection and understanding and making plans and seeing what's going in the way and coping skills. And that's what we do. So you see this picture here where there's this brake pedal and gas pedal. And it's great when our health can be in balance, but so much of stress is about when my brake pedal is slammed down all the time. This is what's happening literally with my organs, right? There's cortisol rushing through it. And same thing, if my brake pedal is slammed down all the time, we're going to start to see health issues in these areas that really impact us down the road and cause inflammation if my heart rate is always up all the time, or there's always these stress hormones. Right? And so if we just,
No, yeah. So I am getting confused here. With the gas pedal, my airways relax.
Yes, because I need as much oxygen as possible if I'm sprinting away from a bear, right?
So then that does make sense. And I did see a bear on the trail not long ago. The brake pedal, then my airways tightens because I don't need as much oxygen. Is that what?
Mm-hmm.
Okay.
Yeah, and think about like a balance of a brake pedal is good, but there's sort of an extreme brake pedal. Like if my nervous system just isn't getting enough stress, or that stress is so overwhelming that it actually shuts everything down too low. So think about, I'm so stressed, my stomach hurts all the time. And now I've got GI stuff, right? And I've been to every single doctor and we can't really figure it out, but it might really be about that brake pedal being down, right? Yeah. And so when I think about, Russ so often says that we're these specialized healthcare people, this is what we do. We help people with stress. We help people figure out how to make small changes. We don't have to learn all the health issues or all of these organs on the slide without doing that. So I can remember the first time I saw some images in integrated care, I'm like, I don't know, is that the liver or the lungs? Like, I had no idea, right? Like, you will learn more, and you already have what you need, because we know how to connect. We know how to help people use skills to decrease stress, which always supports people in working on their goals.
So some of the tools, so this is where we're talking about clinical skills, and just this is a public domain, standardized brief screening tool for depression. I suspect you've heard of it. Maybe you've even gotten it when you've gone to your primary care physician, because your medical home, your medical provider can bill at a higher rate if they're also assessing for some behavioral health issues. And they have to choose two. A lot of them will do like depression and alcohol use or substance use, but they could also do anxiety as well. But this would be a specific tool that I would definitely, as a clinician, as you're getting ready to go into practicum or internship or graduate, I would want to have this on the desktop in a folder of like helpful integrated care tools. And the PHQ-9 would be one of those. I like the PHQ-9 because it can be a discussion with a client. And that's how we would do it. It's like, because first of all, we need to assess for the ability to understand and read. I've had clients where that was very difficult. And so I can actually work with them on this to try to figure out where they might fit. That'll be important. But then making a discussion, feeling tired of having little energy, there may be some context for that makes perfect sense, but we want to be able to talk about that. And again, in the public domain, created by Pfizer, I have gone and looked at some of the psychometric properties, and it looks fine in terms of reliability and validity. There are no perfect assessments. There could be some language issues in here we'd want to address. So again, it would be a discussion piece, but I do think the PHQ-9 for counselors would be something that you would want to keep close at hand. And they do have, I think on the next slide, Katie, they've got, there's different algorithms you can find. If you go into your medical provider and they're always looking at a screen, they're running through the algorithms based on what medicines you're on and what you scored on this and so forth. And this just kind of also gives a little bit of a guide. For instance, if somebody scores in the moderate range for depression, we may encourage contact and even create a referral to a behavioral health provider. And there also may be a script written for some type of antidepressant medication, but it just gives you an idea of kind of where you might go. I like the algorithm just because I want you to know that that's something that the medical providers are using a lot. And yeah, if you're ever wondering why they're looking at screens instead of you, they're running through the algorithms to make sure they don't miss anything. I definitely need to get a better slide for this. I think I like this one just because there are just online versions that you can use. So this is one I found online for the GAD-7. Again, I looked at the psychometric properties and it seems fine. Again, no perfect assessments, but this is for anxiety. And again, it should be a discussion with the client. I believe anxiety has surpassed depression as the World Health Organization most common mental health issue. So again, I know that Kelsey and I were talking before this presentation about how she's got some good experience with both anxiety and depression, and I think all counselors should. That's kind of that's what you see the most of, and then you can kind of have specialties on the side there, but.
And this is really easy to use these days. Most of the platforms that you have, people can fill it out quickly online, and before the appointment, you sit down and it's right there in front of you. Versus like trying to do any paper or scoring. I know the platform I use makes this very easy to track over time. It gives me a reminder like, oh, it's been 6 months. It's time for this person to do this again. And I can click a button and it sends it to them. And whether you're looking at the overall score or just sitting down with someone and reading one of them, like, tell me more about that. And you can end up spending a good part of a session learning more about that person and getting some coping tools about one particular item too.
I'm kind of curious, I know you can't share client information, but is anything that's been kind of surprising by using this with the platform you're using? Or helpful, surprising or helpful?
Super helpful is I can't tell you the amount of meetings I used to be in on how can we remember to do the follow-up when it was like built on systems. So it's just there. I think sometimes what's helpful is there might be a particular item like around sleep, and that would have gotten lost in all of the other items, and maybe you can do some quick things around sleep and someone can really have some benefit right away. So I think that's what's been helpful. Or to share with the client that if you've seen for a while, to really say, oh my gosh, let's look together at last year. Look at how high it was and look where you are now. This is huge. Like, let's not rush past this. Let's take a pause today. Let's really
Yeah.
dive in. Do you feel like it's gotten better? And what have you been doing that made that happen? So that's another cool thing is most of them have these graphs and you can look at years of graphs of their report.
Nice. And I know we'll talk about the session rating scale later, some slides later, but you've included that as well, haven't you, in your
Yes.
Yep. practice? Yeah.
Yeah. And I see Kelsey said, do you ever find yourself discussing the assessment, not validating how the client feels when reading the questions? Will you say that question again, Kelsey, or like say it out loud?
So earlier in our first presentation, we were just kind of briefly talking about the PHQ-9. And I have a client that sometimes that one of the suicide questions, she's kind of like, this question is questioned weirdly because I guess of the specific wording. And so she's like, I have suicidal thoughts, but I'm not suicidal. So I'm wondering, like, do either of you, like when you're going through either the GAD-7 or the PHQ-9, do you also have experience with clients kind of feeling this way?
Yeah, I love that you said that, Kelsey. And I also think it says something that your client told you that, right?
Mhm.
Like it's a good sign when we're using an intervention and a client's like, I don't get that, or this doesn't make, it's such a good sign about rapport. So yeah, I think it like lets you learn more about somebody. Whether I can think of a client who like in their mind, they were never not like, it was almost like everything's hard. Like, so I'm never gonna rate it a 1 or 2 ever, you know? And my
Right.
job's not like, you're gonna have to put a 1 or we're gonna keep at it. But to really be like, that makes sense. And it was almost like he needed a new scale. Like, yeah, from if yours is always 8 to 10, is it 8, 9, or 10 today? Now I know his scale. And let's not assume that all of these are culturally appropriate, even though I know certainly they've tried hard to do that. Or, a word will just hit you wrong sometimes. Like, you're like, that, I don't like that word, or it feels insulting. I think people point that out. Or the word means something different to them. I can remember a survey that really asked people if they were having hallucinations, but the question said, like, do you ever have thoughts that aren't your own? And I would have so many people like start to go down this road that really had nothing to do with mental health. It was just like, we asked a weird question. I think it just opens the door to share. I don't know if you would say something different, Russ.
Yeah, I can just speak broadly from that, and I got this from John Sommers-Flanagan years and years ago in a training. Is that the conversations about suicidal, whether questions or suicidality, it's a conversation. And we want to dive in and find out more information about what people are thinking. So I think that's what I'm kind of getting, Katie, too, is just that we want to find out where a word may have struck somebody different and just find out what's going on for them and how we can best help. So when supervising, that's the majority of what I do now. That's what I'm asking folks to do is let's make this a conversation, find out more about the client, and then determine level of care that's needed.
Yeah, I think even just looking at number 7 right now, right? The world's hard for different people in different ways.
Yeah.
And we could jump to conclusions. Do you feel like something awful might happen? And that not everybody's paranoid, right? Yeah.
That's a good one. Yeah, and the PHQ-4 would be like, if at all possible on your intake, is that we're asking 2 questions from the depression instrument, 2 answer or questions for the anxiety one, and just to get a feel if we need to bring in more screening as a result. So really, really simple, but a nice way to maybe catch initial anxiety, depression. Particularly important in the integrated care setting, since we know that anxiety and depression complicate how we work with other medical disorders. Don't feel very motivated to take medication and exercise and follow nutrition suggestions from my doctor when I'm depressed. So just a simple way to kind of capture that. And Do you have the GAD? You do the GAD-7, Katie, with your okay.
Yeah.
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 My dog doesn't ask anxiety questions. That's interesting.
Mm-hmm.
Yeah.
Yeah. And in integrated care, sometimes you might want to mention as the counselor, like, hey, thanks for filling out those surveys. If they weren't concerned, they probably won't ask you about it. Because then people are like, I filled these out and nobody asked me about them. But it could be because the score, for the physician, they're like, oh, okay, we don't need to address that, but they may not mention it. So it can just be a way of acknowledging, thanks for doing that. So people aren't wondering why no one said anything about it. Because we've all had that feeling, right? I've filled all this out and then you didn't look at it. This is the cage, which really screens for alcohol. But again, this is about being conversational. And really, I encourage you to like practice these questions out loud, practice them with your friends and family. Be careful of the answer, but just get a chance to like say things that feel comfortable to you. Because if it does feel like a screening, people will feel like, oh, is this a gotcha? Particularly around, substance use that has so much stigma. So it can just be very casual, just asking like, have you ever felt like you wanted to cut back? Or, hey, some clients tell me like they got to have a drink in the morning to get going. You ever had that experience? So that we can really normalize this as we're asking about it. And my experience has not been, I feel like you learn all about the stages of change and they're like, there's all these people in denial. And my experience has been that's really few and far between, that most people with substance use they realize that this is a problem and actually they have tried to do some things about it. And maybe they're not ready to do it. They don't want to. Maybe there's some big scary things, but that they're fairly open to saying like, yeah, this hasn't been easy, or yeah, I kind of wish I could cut back. This is the 5 A's. This is specific to tobacco use. And I think why we wanted to include that is I think there's a lot of wonderful and great training around addictions and substance use. Opiates, meth, all of those things, alcohol, and all of that is really important. And the majority of those people struggling with those substances are going to die from tobacco-related health issues. And so I know that for me, it's like this can fall off my radar when there's these other substances. This was studied initially with doctors, with prescribers. And the reason I tell you about that is you really just do follow the formula. But it's first to say, to find out, how much are you smoking these days? That's how I ask the question. I don't ask people, do they smoke, if I am pretty sure they are, so they can say, oh, I don't smoke anymore. Okay, so make it conversational. I believe it says advised to quit because it was done with doctors. And my hunches are something about like an expert in the room where like the research said, if I say, I think you should quit every time. I would never say it like that. But if I knew that was important to that person, I might say, I know it's been really important to you because you want to be around for your grandkids to quit. So let's keep working towards that goal. So we might say that differently as counselors. The assess is really like, really finding out from them, are you wanting to quit at this point, or have you been more thinking about cutting back or just learning more, so that you're really assessing where they are in their stage of change. And then we can assist them where they are at. Like if they want to quit, let's get the resources and help them do that. If they're really saying, I'm not ready to make some changes, but I'm open to talking about it, then we might say, great, let's just start tracking like when you're smoking, how often you're smoking, and even like what kind of day you had, like something simple. Or you might just be asking for permission to like, would it be okay if I asked you about this another time? If someone's like, I don't want to do anything different, we can just ask for permission in the future, and then really arranging that follow-up to do that. So if someone's motivated, like time is of the essence. You're like, today I'm going to go take care of my health. I'm going to start going to yoga. I have that thought all the time. I don't go, right? It's like we want to take the window when someone's ready to do something and really follow up within that week. So the 5 A's, these are great to just like print off and have near you. And I know you guys heard already today from someone who really has some expertise in talking to people about suicide, but I did want to include the Columbia again, because I think it's a great tool that you can just go look up, that can really walk you through some questions to ask, that you can practice some of those questions so they roll off your tongue in a way that's very conversational and also direct, and you can get some practice with that. And then in particular, the Columbia does really guide you with oh, this is low risk, here are some things to do, here's medium risk, here things to do, and here's high risk and things to do. And then this statistic is really potent and important when we think about integrated care, right? That most people who have an attempt, they weren't on a mental health counselor's radar often. That's what we know. It's not necessarily they weren't in treatment. And the 64% who attempt did have a visit with their doctor during the month. So I don't think we know why that is or whether they, that was connected, but this is such a great way that someone may never come to a private practice office, but they do go to the doctor. And so we're in such a great place to catch some of these folks.
I am kind of curious with this because I did, when looking over John Sommers-Flanagan's slides, that I don't know if James or Kelsey or anybody else out there, was there mention of not using the Columbia anymore? That does it get in the way? I didn't know if y'all had some insight.
He mentioned that using the Columbia, because the Columbia was the golden standard, he kind of ruled against using the actual PHQ-9. He said the Columbia was actually a better fit for suicide than the PHQ-9.
Yeah, that makes sense. Yeah. Again, it's a conversation, but I do think these questions are kind of decent to keep in the back of your mind. Yeah.
Yeah. I've never worked anywhere where the counselor used the Columbia. We used it for training purposes, but I have worked places where the medical team used the Columbia when there wasn't a counselor available. And I feel like that's telling it's just my experience, but it's like when there wasn't a clinician, here's this thing I can follow and say that we've done something and we've got a plan. But when there was a counselor, here's this person that knows how to be in connection and knows how to talk to these folks in a way that they'll feel safe.
And James, you've got something?
Yeah, I just wanted to say briefly that here in Texas, at least in our local mental health authorities, like within our respective county, whenever we're working in an integrated care setting, counselors and medical providers are required to administer the Columbia Suicide Severity Rating Scale if they're ever working with a client that has depression. And there was a period of time where we were required to do it every session with a client that had a depressive disorder. And so it was, I think, more so for research purposes, just to see how helpful it is as a tool to prevent suicidality. But kind of going along what Dr. John Sommers-Flanagan presented earlier, he was just saying just how difficult it is overall to predict suicide anyway.
Yeah.
Because it's he mentioned a wicked problem, right? It's a very multifaceted issue with a lot of different compounding factors. And so really at the heart of it all, he was just kind of letting us know that like we could still miss a lot even with using tools like this, and especially like the PHQ-9. While that is a very popular tool, it shouldn't take the place of like a standardized like suicide risk assessment. And so that's really some of the things he was also mentioning.
That's helpful. I look forward to seeing that video of him, because that's where I learned about suicide assessment. Is really from his workshops. So,
me too.
Yeah. Thank you for sharing that. Katie, I know that did you want to take this one? I know that we've got different experiences in that I'm born and raised in the South, and I am a gun owner, and was taught to shoot guns when I was 7 years old. And so this really kind of rings true about, at least in the South. And I know that being raised in St. Louis, there was a different kind of idea about gun ownership. I don't know if you want to share that or, yeah.
Yeah, this site is really about lethal means counseling. And if you haven't done it, there's a great resource called CALM, which was, I think, originally developed by the Suicide Prevention Resource. But it's a free online training that you can take about removing means. And it really has some great practice at having conversations. So that's where some of this comes from. But yeah, where I grew up, it's like looking at your own biases and experience. It was like guns were bad, and if you have a gun, it's for a bad reason, and something bad's going to happen, right?
And
like
so
that's what I came into the field with.
Yeah.
and had to just pay attention to that and really learn about the culture that I moved to in the South, that, as Russ described, where absolutely there's responsible, some of the most responsible people are the people with guns, right? And that was probably true in the city, and I just didn't know about it as well. But yeah, so getting comfortable talking to someone about during a heightened period of risk, right? We just want to create as much distance between this lethal mean that can do something very quickly and you just during this heightened period of risk. And you see here just a couple of ways that you might be able to say those things. Anything you want to add there, Russ?
No, I've always appreciated this, and this has been kind of new on the radar. Yeah. I think just when I think about just being, again, raised in the South, and that, man, that was, yeah, and people get really heated when you start talking about taking their guns and stuff. And so it's like, that would be a way of really alienating a client is if you are just automatically, you can't have them, you got to give them away, and then you're not going to be working with them, and then maybe higher risk. So I think this is really important, and just particular in the area where I was raised. Yeah.
And I just picture myself at 22 or 25, sitting in a room with a 65-year-old man who's lived on his land for generations and has his great-grandfather's gun. And I'm really glad I've gotten a little bit better, so, and still have room to improve. But what that would be like for them, like, who are you, right, to talk to me about this? Yeah. And so it's just putting that time and distance. And this can be, when I think about parents and teenagers, this is about having a whole bottle of Tylenol, right? That's cheaper at Sam's if I buy the big bottle than at Target if I get the small bottle. And even talking to every parent with teenagers, because they might have other teenagers in the house, of not having that huge bottle of Tylenol available for everybody to get. Maybe there's a bottle of Tylenol that has 10 in it, because 10 won't kill you, but an entire bottle of Tylenol, right, can kill somebody. So putting a little time and distance when there's any kind of concern, and that's really what it's about.
Yeah. Now, this may seem a little disparate, but what we also wanted to, as counselors, is to recognize some different conditions that you should have some general knowledge about, and recognize that these conditions have mental and physical health issues related to it. I particularly like, we're going to talk about several, but I particularly like this one because I find that folks will talk more easily about their depression and anxiety than they would about irritable bowel disease, even though I don't watch a lot of TV anymore, but I know, like, if I catch a little bit of 60 Minutes, there's all kind of medication commercials related to this, Rinvoq, for instance. But irritable bowel disease one, and another thing I want to point out is that the silent chemicals that are in our waters that we all have, they don't know a safe level for that. They're all there. They don't know the safe level. These silent chemicals were created to create water resistance on pans, carpets, drapes, clothing, or even in makeup. And there is a link to that in irritable bowel disease. And this affects every area of somebody's life, relationship, the type of career that they can have, how far they can travel, maybe to visit family or what have you. So just keep in mind, this is one that I don't see taught a lot about, and I think it's one that we need to bring to people's attention, in particular counselors. And I'm sure you could line up probably 30 different illnesses that we need to know more about, but I do think there's some big ones that folks don't talk about, and this would be one. I also just wanted to say, hey, I'm doing my practicum or internship, or what exactly do I do when I walk into the room with somebody? And so I just wanted to create kind of a funny acronym, Dr. Help, of like, all right, you're being called into an exam room. What can you do kind of quickly that could also be effective? And first of all, discuss the issue. Perhaps put it on a rating scale. So again, we can engage the prefrontal cortex. We can also get kind of a score that we can then monitor. What's helped them feel better? What have they tried? This is something I think that's missing in the medical profession a lot, is that they come charging in, they've only got 7 minutes with you, they hear the concern and they prescribe something. We like to also say, hey, what have you tried? I bet you've tried something. Maybe it's herbs or what have you, and gathering that information. Then explore perhaps exceptions to the issue. When is this anxiety less problematic for you? Could you pay attention to that between when I see you next? And maybe, and this one, it depends on kind of the context and so forth, but like, hey, what would a new and better chapter look like for you? This is very solution focus oriented, but it sounds like right now things are not great. What could we begin today in a little bit of time we have to start writing a new chapter to where you are able to feel more meaningful, thrive, feel less problematic with issues and symptoms. And then being able to discuss past successes with similar problems. And what this is doing is when we think about the successes, we're lighting up those neurotransmitters because everybody has probably had a success. Now, I might have to give an example so that a client can kind of access that. And I wouldn't expect every client to be able to access it. But what we're hoping to do is light up those neurotransmitters so that we can start building that pathway or cutting the weeds from the pathway of, oh, I can find solutions. When I'm in a decent spot, I've done it in the past, I can find solutions. So start to, again, we talked about the depression and anxiety neuropathways, or a 4-lane paved highway or 8-lane. We want to help them start to recognize, oh, I can find solutions as well, particularly if I ask for help, collaborate, and rely on kind of my strength. So just kind of a very simple, practical, what do I do with a very quick, within 20-minute session?
So you see here the stages of change. And this can be something just really lean on at any time. We can share this with clients. So sometimes I'll share with clients, give them an overview of what stages of change are to really normalize, like, this is really hard. Like, most of us spend most of our time in those early stages of change. If we were all in number 4, if we were in action, we probably wouldn't need the support, right? So this is, I think our system sometimes is built to support people in 4, 5, and 6, but most people show up in 1, 2, and 3 in these early stages of change. So we want to know it, teach it, share it, use it. I think it increases our compassion when we realize how much work there is to be done in these early stages of change. We can really honor where people are at. And I also notice anytime I'm frustrated, if I think about, okay, where is this person in their stage of change? And then where was I supporting them? Often there was a mismatch, right? That I was really trying to work with someone in action stage, but actually they're still in contemplation. Like, yeah, I know I should do this, but I'm not quite ready. And so this can be a way to honor someone around any kind of change. This really was designed for substance use, but I think it can be really helpful to think about it with any kind of change around health that someone's going to make, and to know that folks in pre-contemplation, it might not be that they don't know they have a problem, or it might not be that they are in denial, but sometimes they might just be too overwhelmed, right? Anybody like know you need to change something, but there's way too much on your plate to like let that be front and center. Yeah. And then to follow up, this is like a nice chart that can be used in integrated care. This is how you can close a session. Once we're kind of know where someone might be, is there anything you'd like to do for your health in the next week or two? Right? And if someone says no, then we say, great, I look forward to seeing you again, right? That we don't have to push it there. But I think I only had that happen a few times. But really say, oh, do you have an idea? Right? And if they have an idea, we can really start to go in this goal setting. We can set some menu options. Are you thinking about this or that? And really just collaboratively help them. And then really in that time, and this can take just a couple minutes, to ask that scaling question you see at the bottom there. How confident do you feel about carrying out your plan? And if someone says, oh, I'm a 3, 1 being low, 10 being high, you might even say you're a 3. How come you're not a 1? And we get to hear like what things they might already have going for them. Like, let's start with the strength, right? Or maybe after we ask that, we're saying, oh, you're at a 3. What do you think we'd have to do to get you to a 5? right? So we're just moving the needle just a little bit, but this doesn't take a lot of time. I learned from Russ, I have a stack of index cards. I put quotes on one side, and the other side, we might write a little thing on these index cards for them to take with them. And often it's based off this last piece here. Anything you want to add there, Russ?
No, I just think this is a nice, simple way to engage people and let them know that we're interested in their health. And yeah.
This is just a sample of, this is particular diabetes. They call these bubbles, but you can make your own, but really is a visual for people that might need something visual of, hey, there's all of these options and it's up to you. And I'll often tell people like, hey, I know you said you would make some changes. Would you like to look at some options? We look at this together. And first I tell them, cross out anything you just really don't want to do, right? It's like, let me get that rebel part out. I know I have that part. Or that we're going to put on hold. And then you'll see there's empty bubbles so that we're not saying I have all the ideas and I have all the knowledge. It really is like, what have you been thinking about? And hopefully visually what we're telling people is, yeah, this is a big thing or a big problem. Maybe they already know that and everybody keeps telling them that. But there's actually a lot of different things we can do about it. So it just creates some hope about a path forward. And those were from Kaiser Permanente, actually. Same thing. Sometimes I just have a list of things like, hey, here's some other things, you know, clients pick different things. Which one would you want to explore? If you're trying to help somebody kind of get their problem solving brain online, and they can kind of see, oh, there's lots of different things I can do, maybe things they've thought about or not. And it's not so intimidating as when someone asks you, like, what are you going to do about your health, Russ? It's like this big question in the room. It's like, hey, there's lots of things we can do. Did any of these interest you? And notice one of those, I've got my own ideas or something else entirely.
I should eat more of that food. I did have an apple today. I recognize that we've got about 10 minutes left and about 10 slides left. So I know that we'll have to kind of move quickly, but the main thing is I think particularly with integrated care, since that's what we're focusing on today, that solution-focused therapy is a good model to consider. And I know that I'm dealing with somebody who's a little more novice in counseling. If they're like, yeah, I like solution focused because it's about solutions. It's so much more than that. And there's good videos with Insoo Kim Berg demonstrating it. And I've actually seen her live demonstrating. So highly recommend. But also, I do think this is a good model to consider when working within a setting that's fast paced. So I think that's all I need to say with this one. But I do, yeah, that's a good model to learn.
Yeah, and just looking at this, you'll see this as like a communication card that really helps someone scale how they're feeling. So this is particular to COPD, but they are out there about several different health issues. And just real quickly, we had a client who was older and man, she was Spitfire. Like that was just her. Like she could show up in a room and make some things happen. And anytime she showed up at the ER with some anxiety, it ended up like full workup, right? Because she was an older woman with COPD and there's a lot of liability. But we were really able to just help her start using this chart for her to see it a little bit different and coordinate with the ER that actually before they admitted her, they would call our crisis line and we could walk through this chart with her, which a doctor, our integrated care doctor, made with us. And we actually got her cheap pulse ox where she could measure her own oxygen to see how things were going and the amount of ER visits that saved. I wish we had added up the cost of that. That would have been helpful.
Yeah.
But these things are available out there. These communication cards can teach us a lot. And then shared decision making is really just this concept of when there's decision to be made about medications or treatment or coming off medication, we really want to make room for that, do that collaboratively. And there are some pretty cool decision aids out there that help us do that. So I'll show you a picture. So this is online through the Mayo Clinic about taking an antidepressant, and it really lets the clients click through like, how much worry do I have about side effects around sleep or sexual desire or cost, so they can have some input. So it just becomes a third party in the room that someone can really make an informed decision or weigh in about what's important to them. And some of the research behind shared decision making often just says that we actually don't know often what's important to someone, that when we use these tools, we find out that, man, they were really worried about coming off this medication down the road, and we thought they were more worried about, let me get on it right away. So these are great tools to use. And we won't even here. There are lots of models out there about how to talk to someone about stress and their body quickly. This is just one of them. There's the community resiliency model. This is resources for resilience. But it's just this idea of, do you have a tool that very quickly you could share with someone that they could relate to? So in here, we talk to people about, hey, when you're in that light green, you know how to manage stress. You're using your tools. You're connecting with other people. What are you like when you're well, when you're in that resiliency zone? Learning from them about their strengths and connection. And then we sort of normalize to say, yeah, but these big jolts come, these stressors come. We could ask people, what are the jolts? What are the stressors for you, or triggers, as we often call them? But when that happens, it comes in the body and we can get all amped up. We get anxious, we can't concentrate, we're snappy. Ever happen to you? Or sometimes when we get stressed and all that energy comes to the body, we get on shutdown. We just can't think. We can't make decisions. We just want to hide out and not see friends. And as this is just one model, that's a really nice model, very quickly, people will be like, oh, that's me. That's me in that amped up space. And now we can support them with some tools to get back in their zone. It can also be a nice trauma-informed model to talk about patients, to say like, man, she's really been on shutdown, or I know he comes in here amped up a lot, to have a model that's really respectful of how people show up. And behind that, is anybody seen Daniel Siegel's hand-brain model? I teach almost every client I've seen the hand-brain model, especially if they are caregivers. We won't do that today, but Daniel Siegel has a real short video. It's 3 minutes long. You can watch him describe it, but it's really teaching people, this is how your brain works when you're stressed, and it's very respectful. It normalizes. Russ mentioned the amygdala. It explains it in simple terms, that we have this threat response and we go offline and we don't show up our best because we don't have access to our frontal lobe. We call that, we flip our lid. But it's really giving people the owner's manual to their own bodies and nervous systems, right? Really empowering way to do that very quickly. You can teach it to someone in less than 2 minutes. And it can become language that you use with that client and even with the team. About what it's like when there's stress happening. Yeah, and I just think we're going to see more and more and more of this in integrated care, cognitive decline, and I think we're going to have more and more tools to happen, but just thinking about all the different areas as we think about supporting the aging population, and even people that are quite young that are having these cognitive declines or complications. Just to pay attention to, there are some screening tools, that there's multiple causes. We don't want to make assumptions. Hopefully there is someone who has some expertise, even if it's not you, that you can send somebody to. But I think the real work that we can often do in integrated care is we can often support family members who are going through a whole bunch to support this sudden change and they're not quite sure what to do. I think that's all I want to share about that. Did I miss anything there, Russ?
No, just I agree with you that being able to support family members, and I think about some studies, particularly looking at mindfulness, where they were like, all right, what's the most stressed population we can find? And those are the people they recruit, or folks who are caring for people with dementia. So just understanding how stressful that is for the family.
And you've got this in your slide deck, but there's some tips about sleep hygiene and those motivational interviewing rulers that Russ and I talked about. And I'll leave it here for you, Russ.
Yeah, but this is another thing that you added to your practice, and there's good research behind just checking in with clients and doing quality assurance. And I do think this is kind of a weak point for the counseling profession, maybe all behavioral health profession. You think about, when I go to my physician, when I get done, I almost immediately have on my phone, like, how did we do? And if I get my tires changed, almost immediately afterwards, how did I do? And we've got good, and we don't do that enough, I think, in the behavioral health world. And this is a nice way. I particularly like with Nicholas Cummings talking about reducing formal complaints against mental health professionals, that when we're checking in at the end of the session, I've used this, and not every session, and it usually creates some good conversation about what was working for them, what didn't. I even heard once that they wanted me to actually educate more because I kind of come from the really person-centered humanist standpoint where I'm listening and reflecting, but they were like, no, I want to hear more about, kind of your knowledge related to this illness and so forth. So I think we get good information and it can reduce the formal complaints. Nicholas Cummings, by the way, was a really kind of pioneer into integrated care. Gosh, did I hear him speak? I think I did back in the day, but so it's also tied to integrated care, but it's just something I see kind of missing in the behavioral health world. This is what one looks at. They are in the public domain, but they're hard to find. So Scott Miller, if you go to his website, you can eventually get there, but they've got one for children and even young children. And I've seen some really funny ones. We've got a site that works with folks on the spectrum, and they get to draw whatever they want. And so it's just really cute to see what they draw, and they're given plenty of freedom of how this session went for them. So I just love that. And yeah, very last slide without our resources, but I do think this would be another area. I think the behavioral health and counseling, well, counseling in particular, not psychology, spends some time with it. But since we're looking at dark triad traits, probably affect 6 to 8% of the population. However, our clients can often be affected by folks with these traits. I look at it also when we just look at society and think about the injustices, inequality, oppression. Where did that come from? Who are making those rules and laws? Or who are changing laws that protect people against this? So this is just more of a, hey, don't forget the dark triad traits. When we're teaching and learning as a counselor, we need to pay attention to this. So it may be a small percentage of our clients, but we need to know what to do when it shows up. And this is our contact information, and we would love to field questions. And also keep in mind that this is on a 20-minute kind of cool podcast, this whole lecture. So if you want to revisit it later before doing practicum or internship, you've got it. And I do appreciate y'all inviting us back, and I can hang out for any questions, but just thanks again for inviting us to this.
Yeah, thank you both so much for an outstanding presentation. This was very, very helpful, and I love the resources that you shared. And so does anybody have any questions for our presenters? Well, I want to thank you all for showing also the various kinds of assessments that we can use. I think that these tools are very useful, and it's nice to see the actual items. And we do go over them a lot in our program, but to be able to see them again and kind of see them collectively was good, and it really tied well into the previous presentation too. And then, yes, as Kelsey said, we will send out the slides for the presentations. And we're going to upload them on our Tex-CHIP website. So they'll be up there for people to have access to see them.
Nice.
But yeah, thank you all so much for all the help and support that you've given us. And so this was outstanding, and we're really grateful. And we really love the focus too on integrated care and the roles of different helping professionals. So this was really nice.
I also appreciated normalizing the tough conversations as well as also, I liked how you put it, to have a conversation going through the assessments and not just saying like, here, take these. I liked how both of you integrated that to be a conversation instead of just, hey, take it. I know for our practice, we have simple practice. So Katie, I kind of know what you're talking about. When it's like, hey, you need to retake it, or hey, it's not that time. So thank you so much. I enjoyed you guys today as well.
Well, thank y'all. Thanks for having us. And I know y'all got to be tired after 4 hours. So.
Well, I really appreciate everything y'all have done. And I want to also commend our participants, our Tex-CHIP students. So thank you all so much for being and staying here. And we'd love to hear y'all's feedback too. And so this concludes our symposium. So I hope that y'all have a great rest of your day. Enjoy the rest of the weekend, and we'll be in touch again.
Thank
All
y'all very
right, take
much.
care.
Really appreciate that. Thank y'all.
Thank
Bye.
you.
Thanks.
See ya. Bye.